Done.
Yeah, where to admit all. Admit
Just wait.
all
That I'm
yeah.
going to do. I'm going to remove that waiting room also.
Yes.
Done.
So we are starting with our ninth.
Just wait for 30 seconds. 30 seconds, Dr. Manish.
Okay.
Right time now.
Yeah. Exact 6:30. Good evening, everyone. So today we have all of us have logged in for the ninth webinar series on CRISP, that is the Clinical Reasoning and Problem Solving webinar. Today we are going to discuss a very important topic, anesthesia for thyroid surgeries. We do face such patients very commonly because thyroidectomy is the commonest procedures which we do in a practice, and we do face cases with hyperthyroidism, hypothyroidism. These patients may be diagnosed right from the beginning, or we may diagnose them clinically with the investigations when they get admitted in the hospital. So Dr. Bajwa has already published an article on anesthesia for thyroid surgeries, and he has mentioned the name as never-ending challenges. Yes, very true. As sir has mentioned in his article, these challenges are never-ending, and we really need to discuss it clinically day in and day out, so that when we face such patients, we need to prepare these patients preoperatively, intraoperatively, as postoperatively. So let's begin with our clinical series on CRISP. And we have eminent faculties today, Dr. Paul Rafael and Dr. Ruchi Tandon as chairpersons, Dr. Sheetal Dalal, Dr. Smriti Anand, and Dr. Stalin as faculties. And we have very good academic moderators today who are very enthusiastic in their clinical practice. And they are really doing a lot of good work in anesthesia fraternity. So I take this opportunity to introduce these academic moderators. Dr. Neelam, madam, will you share the screen?
Dr. Manisha.
Yes, sir.
Before we start this thing, I just have to tell the audience, there is a chapter in the Lee Synopsis of Anesthesia. The book, which has been published by the Britishers for a long time, they never include the Indian authors in that.
Yes.
In 2022, it happened such that they saw my publishing work, and then the first Indian, Dr. Sukhwinder Bajwa, is one of the author for the anesthesia for endocrine surgeries. So I had given them almost option for 8 endocrine surgeries. They included 3. But that chapter was published in the Lee Synopsis in 2022. And today's speakers, what are going to speak? They're going to do out of the borders, because the last 2-3 years, more things have come into fray for that endocrinology surgery as well as the management of these post-surgical operations. Dr. Smriti, Dr. Sheetal, they are all well versed in these type of things, and Stalin is underknown to these type of things. So all these 3 speakers, they are going to be wonderful, and we know that this session is going to be very helpful for the PG students, for the practitioners, as well as for everyone around, because these type of surgery you encounter almost in 1 in every 4th or 5th case in your normal daily routine practice. And I'm proud that Dr. Neelam Nalge and Dr. Vartika Agarwal, under the auspicious guidance of Dr. Manisha Katikar, they are going to hold this class in a very good manner. So my best wishes to all of you before we start this class. So I think it's the right time. Dr. Manisha, you please carry on from here on.
Thank you, sir. Thank you for your guiding words. And I'm sure all of us are definitely encouraged by the guiding words which you said just now. So, Doctor, I want to introduce Dr. Neelam Nalge. Dr. Neelam is an enthusiastic anesthesiologist from ISA Borivali. She is a private practicing freelancing anesthesiologist. Neelam, can you share the screen? Freelancing anesthesiologist. She has done a lot of work for the betterment of ISA Borivali. She was a scientific secretary for the Mahayuvakan conducted last year. Not Mahayuvakan, it was ISA Maharashtra CME, which was conducted last year. And the scientific program was wonderful. Welcome, Manoj sir. Manoj sir, Treasurer ISA National. Welcome, sir. And welcome, Dr. Sunil Sethi, sir. Sunil Sethi, sir, is a senior most GC member. Welcome, sir. So, Dr. Neelam, if you are not able to share, please unmute yourself. Okay, in the meantime, I'll continue introducing you. I'll continue introducing you, and then in the meantime, you can try sharing. Dr. Neelam is a very good writer. She has already written in our MISA News. I hope she has participated in our ISA essay competition also, because I remember she received the first prize in last year's essay competition, which was conducted by ISA Maharashtra. Let me welcome another enthusiastic anesthesiologist from my own city branch, Dr. Vartika Agrawal. She has anchored many programs in our ISA Solapur and is really doing a wonderful job as a mom as well as an anesthesiologist. She has already done her regional anesthesia course at Sancheti Hospital, Pune, and is doing good work in the ESIS as well as in her private practice in Solapur. Welcome, Dr. Vartika.
Thank you, ma'am. Thank you so much.
Thank you, madam.
Yeah.
I'm so sorry I was not able to unmute myself.
Yeah, it's okay now.
Ah.
Will you start the program? Dr. Bajwa
Yes.
sir has already given his introductory speech.
Yes, madam. So thank you, madam. Before starting the program, I would like to take this opportunity to thank ISA National, Bajwa sir and Manisha madam for this opportunity. And a very good evening to all of you. We are going to start our program, and I would like to share. Just give me 1 minute. Yes. So I would like to welcome our first chairperson. You all can hear me?
Yes.
Manisha?
Yeah.
Okay.
Very much audible,
Sorry.
madam. Very much. Please go
Sorry,
ahead.
this initial glitches of the web. So I would like to welcome our first chairperson, Dr. Paul O. Raphael. Sir is a vice principal, professor and HOD of Department of Anesthesiology at Malabar Medical College and Research Center, Calicut. He is director of Scientific Committee of IRCF. He is a vice chairman, Emergency Life Support, IMA Kerala State. He has a vast experience of 28 years of post-MD and is an examiner for MD and DNB examinations. He is a faculty in national and state anesthesia conferences. He is an instructor on DLS and SCLS of HA and IRCF. His areas of interest are emergency medicine, public awareness programs, and honors to his credit are Honorary Secretary ISA Kerala State Chapter, Member Editorial Board of IGAA, and awards received are ISA National President Award for Public Awareness 2021 and 2018, ISA National President Proficiency Award 2022 and 2019, ISA President Appreciation Award both national and state in year 2016. We welcome you, sir. Paul, sir, you are there? Our second chairperson is Dr. Ruchi Tandon. Madam is professor and head of emergency medicine department and professor anesthesiology at Gandhi Medical College and associated Hamida and KN Hospital, Bhopal. She has clinical experience of 22 years. She is a teacher for MD diploma and CPS exam. She is a thesis guide for the students. She is a journal reviewer. Madam has served as ISA Bhopal Secretary and President, ISA MP Vice President, ISA Central Zone Vice President. Her interest and expertise are obstetric, pediatric anesthesia and emergency medicines. Madam is a recipient of MT Bhatia Gold Medal and she's a faculty at various national and state conferences. Madam has 16 publications to her credit. Welcome, Madam Ruchi Tandon.
Thank you so much. Thank you so much, ma'am. It's an honor being here.
Vartika, Madam.
Good evening, everyone. Next, I would like to welcome the speakers for today. First, Dr. Smriti Anand ma'am. Dr. Smriti Anand ma'am is Professor, Department of Anesthesiology, Maharishi Markandeshwar Medical College and Hospital, Solan, Himachal Pradesh. She has teaching experience of 17 years. Her interest and expertise are in obstetrics and regional anesthesia. She's a past section editor in IJA. She has various honors, awards, and publications to her. She was an MBBS gold medalist, guest faculty in various state and national conferences, and she has various publications in her national and international journals. We welcome you, ma'am. Next speaker is Dr. Sheetal Dalal, ma'am. Dr. Sheetal Dalal, ma'am, is Associate Professor, Department of Anesthesiology, IGGMCH, Nagpur. She has a clinical experience of 23 years, 17 years as a PG guide. Her expertise and area of interest are difficult airway, regional anesthesia, and COLS training for public. She has various honors, awards, and publications. President Appreciation Award National 2018, Appreciation Award 2021-23, Public Awareness Award National in various years. She has Mrs. Sindhu Ingle Award. Then she is past President ISNCB 2017-18, Organizing Secretary ISM Mahakon 2021, and she has 14 publications in Index Journal. We welcome you, ma'am. Third speaker for today is Dr. Stalin Sir. He is a professor, Department of Anesthesiology and Critical Care, JIPMER, Pondicherry. He has 15 years of teaching experience. His areas of interest are regional anesthesia, resuscitation, airway, and simulation. He has been awarded as the Best Reviewer Award, IJA 2021-22. He's a past treasurer, ISA Puducherry. He has 40 publications and 3 book chapters, AHA certified BLS and ACLS instructor, and he was invited for faculty for various national and international conferences. This was a quick introduction of all the 3 speakers. I welcome you all for today's webinar.
Thank you, Vartika, Madam. So I welcome all of the speakers and chairperson and all the members who are attending this session. Our first session is by Dr. Smriti Anand. So she is going to present to us a case where 48 years old female with 76 kg weight has a huge diffuse colloid goiter with retrosternal extension. Madam is going to talk about optimization and perioperative care of this patient. Over to you, Dr. Smriti Anand, Madam.
Make it full screen. Dr. Smriti, please make it full screen. Yes.
Is my screen visible, ma'am?
Yes, very good.
So a very warm evening to all the dignitaries who have joined here today for the CRISP series. I'm Dr. Smriti Anand, and I'm going to do a case presentation on a case of a goiter with retrosternal extension. I think there's some problem. I'm not able to move on to the next slide. 1 second, ma'am. Okay, so this is a case about a 40-year-old female who was a laborer by occupation and who was residing in Himachal Pradesh for the last 30 years. And she presented to us with the chief complaints of swelling in the neck for the last 20 years and dyspnea on lying down for the last 2 years. Patient was apparently all right 20 years back when she noticed a swelling in front of her neck, which was small to begin with, and gradually it increased in size to the current size. However, the swelling was not associated with any pain, fever, difficulty in swallowing, or hoarseness of voice. Also, the patient gave us a history of some dyspnea on lying down, which, however, did not disturb her sleep. There was no history of loss or gain in weight, heat or cold intolerance, or any features suggestive of hypo or hypothyroidism. In the past, she gave us a history of tubal ligation, which was done 18 years back in some camp. In her personal history, she was married, vegetarian, non-smoker, non-alcoholic, with normal bladder and bowel habits. Her sleep-wake cycle was absolutely normal, and also she didn't give us any history of any allergy or drug intake. Regarding her menstrual history, though she was not sure of her age of menarche, but according to her, it was around 18 years of age. Also, she was menopausal. She had attained menopause at the age of 45 years. But throughout her reproductive cycle, she had normal regular cycles with normal flow lasting for 3 to 4 days. She was para 4 with 3 live children and 1 abortion. Last childbirth was 20 years back, and all the deliveries were conducted at home by a local midwife. Currently, the patient was not on any treatment, and there was no history of any similar swelling amongst any family member. On general physical examination, the patient was conscious, cooperative, oriented, with a weight of 76 kg, height 154 centimeter, and her BMI was 32 kilogram per square meter. Her saturation on room air was 98%. She had normal facial features, normal eye features. There was no pallor, icterus, cyanosis, clubbing, or pedal edema. There was no cervical or axillary lymphadenopathy. There were no tremors. Her metabolic equivalent score was more than 4. And we could see a large swelling in the anterior aspect of the neck. Her vitals, BP was 140/90 millimeter of mercury in the sitting position in the left arm. Pulse was 90 per minute. Her respiratory rate was 14, and she was afebrile to touch. When we did her airway examination, it was found that she had Malampati grade 2. Her interincisor gap was 3 fingers. Her neck movements were restricted. The sternomental and thyromental distances could not be measured because of the huge swelling. The upper lip bite test was 2, and the neck circumference was around 40 centimeters. Now coming to the details of the swelling, we could visualize a huge swelling on the anterior aspect of the neck, which was around 1 minute now. The left margin of the swelling could not be appreciated as it was under the left sternocleidomastoid muscle. However, the right border could be appreciated just medial to the anterior border of the right sternocleidomastoid. Superiorly, this swelling extended up to the mandible, and as far as the inferior border was concerned, we could not identify it. The swelling did move with deglutition. It had a bosselated surface. The lower border was neither visible nor palpable. We could not insinuate our fingers between the clavicle and the clavicle or the menubrum sterni and the mass. However, there was no thrill or bruit in the mass. The Pemberton's test was negative, but the Cocker's test was positive. So this is the patient with a huge thyroid swelling. On systemic examination, nothing abnormal was detected. The indirect laryngoscopy was done by the ENT team, and it revealed mobile bilateral vocal cords moving during phonation, thereby ruling out the involvement of the recurrent laryngeal nerve. Her hemogram was absolutely normal. Apart from the routine investigations, we got her serum calcium also done so as to have a knowledge of the baseline value, and it was around 8.6 milligrams per deciliter. Her thyroid profile was also done, and it was normal. So on the basis of the clinical history as well as the investigation-wise, she was euthyroid. Her ECG showed normal sinus rhythm, and echo was also done, which turned out to be normal. So on X-ray chest, the trachea was deviated with the superior mediastinal widening. Ultrasound neck was also done, which showed diffusely enlarged thyroid gland with heterogeneous echo texture, and few cystic and calcific areas in between were visualized. The CECT was done. It showed in the CECT, both the lobes of the thyroid gland were diffusely enlarged, left more than right. And it was noted that there was heterogeneous nodular enhancement with 3 by 3.5 centimeter retrosternal extension on the left side, extending above the arch of the aorta. So if we do look into this Hewins grading, this retrosternal extension comes under grade 1, that is, it was above the arch of the aorta. Also, multiple cystic and calcification areas were noted in the enlarged thyroid. Mild external compression of the trachea and displacement towards the right side was also noted. So on the basis of histological examination, her FNEC was done, which gave us an impression of nodular goiter. So on the basis of history, clinical examination, as well as the radiological investigations, a diagnosis of diffuse multinodular goiter with retrosternal extension with mild tracheal compression was made. Now, the surgical plan was to do total thyroidectomy under general anesthesia. So, how I did it? Patient was accepted under ASA 2. A written informed consent was obtained for awake, flexible, fiber optic intubation and post-operative mechanical ventilation if required. The plan was awake nasal fiber optic intubation. Patient was kept overnight fasting. In the operation theatre, difficult intubation cart was kept ready. In the preoperative area, 2 large bore IV cannulae were secured. Patient was made to do gargles with lignocaine viscous 2%, and also she was nebulized with 4% lignocaine 4 ml. Xylometazoline nasal drops were instilled in both the nostrils. Pharynx was sprayed with 10% lignocaine spray. After adequate topicalization was achieved, patient was shifted to the operation theatre and multipara monitors were attached. Dexmedetomidine infusion was started and titrated to 0.5 micrograms per kg per hour. Patient was also given anti-silogogue injection glycopyrrolate 0.2 milligram IV. Ondansetron 8 milligrams low IV was given, followed by 1 milligram midazolam plus 60 micrograms fentanyl IV. A 6.5 mm oral cuffed flexometallic tube was inserted and 1 ml of topical 2% lignocaine was given in added doses via fiber optic channel using spray as you go technique. On visualizing the carina, the flexometallic ETT was railroaded over the fibroscope and positioned over the carina and fibroscope removed. After confirming the correct placement of the endotracheal tube through the visible capnogram as well as the visible chest rise, patient was induced with injection propofol 120 milligram IV and injection vecuronium 7 milligram bolus was given. The anesthesia was maintained with oxygen, nitrous, isoflurane, and dexmedetomidine infusion, as well as with the maintenance doses of injection vecuronium. Intraoperative analgesia was given with 100 micrograms of fentanyl and intravenous diclofenac 75 milligram. Total thyroidectomy was done through conventional Cocker's incision, and the retrosternal part was gently coaxed and removed by the surgeon. No hemodynamic derangements were noted during the entire intraoperative period. After the completion of surgery, to rule out tracheomalacia, a leak test was done, and the leak test turned out to be negative, so patient was reversed with injection glycopyrrolate and neostigmine. Dexmedetomidine infusion, however, was not stopped. Fiber optic guided extubation was done to rule out any injury to the recurrent laryngeal nerve. After ruling out the injury to recurrent laryngeal nerve, this infusion was stopped and patient was monitored in OT for another half an hour and then shifted to the ICU. Her entire stay in the hospital turned out to be uneventful and the patient was eventually discharged. Thank you.
Thank you so much. Thank you so much, Dr. Smriti Anand ma'am. It was indeed a very detailed and insightful lecture. Next, I would like to request our chairpersons for today, Dr. Paul sir and Dr. Ruchi Tandon ma'am, for their expert opinion.
Good evening, all. First of all, to begin with, let me thank the organizers, the national team, Bajwa sir, Manisha madam, and all organizers for giving the opportunity to be here. And definitely, if you see the number, it has almost crossed 200. So that's a very good effort from the secretary, and it is because of the confidence each person have in this meet, the quiz meet. Now, coming to the case, Dr. Smriti has presented it really well. And if you see, if your institution has a fiber optic, definitely like you should go for a fiber optic laryngoscopy. That's the message to the PGs. And another thing, what I would like to tell in this case is like video laryngoscope. Video laryngoscope, see, almost 95% of the job of fiber optic laryngoscopy is done by the video laryngoscopy. So now it is mostly available in all the hospital. You can say like almost all the hospitals. So like we can always use this video laryngoscope. Now coming to the hospitals where these gadgets are not there. That's a tricky situation. And what Dr. Smriti has mentioned is the ideal way to proceed. Now, if you don't have this, definitely you will have to speak to the patient about the difficulties you may encounter. And also, you should be prepared yourself. I mean, even see, I'm heading a department. That doesn't mean that head of the department can do any of the work. You always need a help. You should always inform your colleagues and be ready for all the situations which can arise, any catastrophe. You should have a plan A, you should have a plan B, and you should have a plan C. Like now, earlier days where we didn't have all these gadgets. What if you ask me what we used to do, like when we have a doubt whether there is that Mallampati grading, here it is two. You can say that it's not very means catastrophic. It is two, and if you look at all the other parameters in that, you see all are adequate. So definitely you can try to go for the conventional way of doing it. But you have to keep everything in handy. Now, I told you about calling the seniors and be there, if you are a senior, you should call the juniors. But what is likely seen in many of the institutions, like the juniors will be there, then the seniors will be called, and after the intubation, you will see only the junior person there. But here, what you have to think about is that extubation is also very important, and all the precautions you do during the intubation, that also should be there during the extubation. And we have the medications like rocuronium and sucamadex. If you're finding it difficult, definitely you can reverse the patient. See, what my professor, this is not to what I'm telling to practice, and like what we used to do when you have any doubt in a pre-anesthetic checkup room, like we used to do a conventional laryngoscopy by giving a nebulization or a lignocil jelly. So you'll just see, it will take only 2-3 seconds to just see whether you are able to see the cords or not. And another thing is, like after giving a proper fall, we'll see whether you will be able to intubate, whether you want to give a muscle relaxant of short acting or you have to give a long acting. So you become more confident in that way. But these are not the techniques to be, as a postgraduate, to be told. But when these gadgets were not there, this is what we were doing it. And as I told, estimation is important. The senior help should always be there, and you should be always cautious in your procedures. Thank you.
Okay, I'll add my 2 bits. The case was very well presented, Dr. Smriti. The only thing is, like, it was a very, a clear-cut kind of a case. Of course, you do have these. But as Dr. Paul also said, if we start with your pre-anesthetic checkup, the entire the procedure has to be followed. And what is important here is, because it is a retrosternal extension of the thyroid, the complications must be explained properly to the patient and the patient's attendants also. So this is that we could face during surgery, or we could face after surgery also. Plus, your team, your plan A, B, and C is fine, and your team of an ENT surgeon there, even you may even require on when you're in the OT, you may require CTVS surgeon also. So all these teams should be there. You should have proper preparation for everything. And I think a video laryngoscope, yes, that can be done in, as Dr. Paul also said earlier, what we did was for a large goiter, we had the normal laryngoscope, the conventional laryngoscope, and the normal tubes. Sometimes the flexometallic was also, it was a luxury. But what we used to do is we used to kind of lift the thyroid off the trachea. That was very commonly followed. And I was taught this technique by my professor. So the senior help should be there, of course. Your pre-anesthetic checkup, then your induction. Induction also, we have used thiopentone. Now propofol is there, dexmedetomidine is there. We have so many things in our armamentarium. Then if we come to during surgery, if manubriectomy is required, that should be available on spot. Your the CTVS surgeon should be there. Pain relief should be there, because if sternotomy is required, vesito, normally through the cervical route only, all these things can be, or these retrosternal goiters, they have been removed. And we have never gone for manubriectomy or sternotomy. But if required, adequate pain relief is very important, because they're very painful, that post-operatively. Then during positioning also, first, I missed that out. During positioning, you can face accidental extubation. So accidental extubation has to be kept in mind. And what we used to do is we used to hold the tube in place when the surgeon was manipulating the position. That's one more. Then another is while extubation, as Dr. Paul has already said, you have to have the same kind of your seniors should be there. You're not just because it's towards the end of the surgery, you will just need to extubate the patient. You will require the same kind of vigilance while you are intubating. Then post-operatively, elective ventilation may be required, which should already be explained to the patient. If it's a prolonged surgery, you need to arrange for blood. These small things which normally you should have in mind. And I think the way you have conducted your surgery is it's very good, near perfect, except for a few things that I have given my bit about. Thank you.
Thank you so much.
Thank you, madam. I would like to ask Paul sir one question. Sir, the goiter was very long standing. Plus, patient has history of dyspnea on sleeping. So here, ideally, it should be fiber optic intubation, because once you are inducing the patient, the swelling may fall on the trachea and the airway will collapse. Even if there is a emergency cart ready, front of neck access is impossible in this type of patient. So what is your final take on this intubation? Because many are asking why fiber optic, why fiber optic. So I want you to clear this question.
No. What I was said was in the first to the PGs, the first thing what you have to, if you have a fiber optic, you should definitely go for a fiber optic. Then depending on the expertise and the type of the case, if you see about the airway, I will definitely go for that. And as madam has told, which I missed, is lifting the thyroid by your companion or your assistant there. That definitely helps a lot. So yes, fiber optic you should, and you have to, you can always have while extubation also, tracheomalacia, all those things, fiber optic definitely will help. So that is what I said in the initial statement itself. For a PG, if you are going to do this case, definitely you should go for fiber optic.
Okay,
and
thank you,
depending
sir.
on the expertise.
Okay, thank you, sir.
You can always change your decisions, and with sufficient help, you should use the conventional method.
Thank
and
you,
one more
sir.
thing actually about the ventilator, say what we have seen, just to add on to it, when you explain about the ventilator to the patient, in this case, like most of the patient, like what is happening is they get scared by saying the word ventilator. So like what we used to practice is like, even though like when we explain about the patient to the patient about the case being done, and we need a ventilator, we always tell that we take the patient in, and because we are giving muscle relaxant, the patient will be on ventilator throughout the case. And once after the case, like, we try to remove it, the tube, and if the patient is not breathing properly, we again connect to the ventilator. So that has definitely helped in explaining these patients.
Thank you, sir. Tandon madam, I would like to ask a query. Though we are happy with the leak test, is it wise to extubate these patients on tube exchanger? You have to unmute yourself, madam. We can't hear you.
Yes, leak test is, I think we have followed it and it's stood the test of time. And I can't say about the tube changer actually, but we've always used leak test, and it's worked for us in most of the surgeries.
So we can safely extubate these patients if we
Yes,
are
yes.
happy with the leak test.
Since you have ultrasound, that will also help.
Yes.
Dr. Neelam, shall I add something to it?
Yes, sir. Please, please.
It's a wonderful case presentation by Smriti, and Dr. Paul and Dr. Ruchi ma'am, they have done it beautifully, supported that case. See, in this case, we are talking about the retrosternal goiter, Pemberton positive, and I don't know what else positive is there. The most important part is the duration of the compression on the trachea. How your muscles have got atrophied, your tracheal rings have got accustomed to it, the muscles around it, because the posterior one-third is always the musculature. How much that is atrophied, how much that is functional, that's most important. The leak test just determines how much volume you will be able to inhale when the cuff is deflated, so that you will be able to extubate. But ideally, in the retrosternal extension, the most important part covered is the posterior musculature, which is the most solely active part in determining the tone of the trachea, the musculature, the diameter of trachea. So if that is compromised, how much the leak test is effective in those scenarios, you may not be able to know. But what Smriti has done, the fiber optic. Now, I will just question that in 70% of our hospitals, maybe more than that. I'm just underestimating those numbers. 70% of the hospitals don't have fiber optic in India. Whether it's a private practice, it's a corporate, or it's a government institutions, 70% don't have the fiber optic. Even if you do the fiber optic, you may not be able to know what the dynamics of the musculatures are there, whether it's a posterior third or anterior one-third, because you are just going to see the position of the tube, nothing else. Because these type of things are more accustomed to, more judged by the clinical acumen of the attending anesthesiologist. There are tests to determine these things, whether we go for the physical test, the respiratory test before the induction. Even your ultrasound, your CT scan, your MRI may not be able to determine the dynamics of these type of function. This is not the clinical scenario in these type of cases. And what Smriti did, she had a resource of fiber optic. What about the periphery? Do we have anything? When we induce, whether the trachea of this patient can collapse anytime with a retrosternal goiter. How we are going to do that? In those cases, it becomes very challenging. How to at least get over that situation when the trachea collapses, you are not able to visualize the airway, your bougie, your stellate, your everything, video laryngoscopy even can go, they may not be able to help you out. This is the most important question in the retrosternal goiter. Fiber optic, you may see a chink, you can insert it. But with a video laryngoscope, with the bougie, whether you want to take that risk or not, that's most important in these type of cases. This is important because this seminar, this webinar is being watched by the practitioners all over India. Not today, in the YouTube also later on. And we have to give them solutions because 70% of the cases of thyroid, even the retrosternal goiter, are being done in the periphery, whether someone agrees with me or not. But this real situation, we have to help our practitioners how to go about that in case such a difficulty arises, because after induction, your musculature is going to relax. You may not be able to ventilate with a mask also. That's my question to everyone, to the moderators, to the audience also, how to help in that situation.
So may I answer?
Yes, Ritti madam, you want to say something?
Yes, sir. Yes, ma'am. The scenario which sir has given, I would like to say in that scenario, we need to have a backup of a very experienced ENT surgeon, because just in case we land up in the scenario where we cannot ventilate, we cannot oxygenate, we should have the backup of a ENT surgeon who can do rigid bronchoscopy, and so that we can at least ventilate the patient that ways. We'll not lose the patient.
Yes,
So
ma'am.
we really need to have a backup of an experienced ENT surgeon in that scenario, sir.
Yeah, that's true. If we are able to ventilate the patient, at least we can ensure safety of the patients. But can we go ahead with the surgery in that scenario? That's very important question for that.
Tandon madam, you would like to add something on this? Because then again, extubation again is going to be a problem in these patients.
Exactly, as Dr. Bajwa has said, if you have faced such a situation, it is questionable whether you should actually go ahead with the surgery if you do not have the resources at your institute. So I think it's better to defer, get expertise, or better to shift the patient to you get either you get experts inside the OT, or it is better to shift the patient to a more equipped center. And this is actually where PAC comes into play, because if you know your limitations initially during PAC, and you have observed the patient, seen the patient, examined, done all the tests, then it is up to you whether you actually want to take a patient of retrosternal goiter in a limited setting of your institute. That is actually a point of contention here.
Well said, madam. Dr. Ruchi ma'am,
There
very
is-
well said. Yeah,
Yeah.
when we take such patients in private practice, in our setup, we must know what are the preoperative assessment is very important. Preoperative optimization is very important.
important.
Airway assessment is very important. And if we feel that we are equipped with all airway facilities, and even a fiber optic is standby, then I think such kind of retrosternal extensions with extensive compression causing dyspnea, dysphagia should be done in a setup where everything is available. Even in private setups, though fiber optics may not be available at every place, but many of the anesthesiologists or the intensivists are having their own fiber optic bronchoscope. So even that can be taken help of at the time of, means they can be also involved in the case. So we really need a good teamwork in doing such cases.
Dr. Manisha, you are right here. I think in such scenarios, it's not the ego of the anesthesiologist. We are not fighting for the glory. We are not fighting for the glory that we can manage this case in whatever way we can. We have the knowledge, expertise, or we have seen those cases so many times. It's always prudent that at least if these type of cases are not manageable in our setups, especially in the peripheral clinics, at least we should have our ego. As anesthesiologists, we are taught that in our post-graduation career also, that never have an ego when you are dealing with a very difficult case, especially related to airway, because these cases can make your life like a hell in the coming future. In such cases, I think it's always prudent to refer these cases to a little higher center where the facilities and amenities are there. A team is there. A one person can make a mistake out of the curiosity, out of the glory, out of the self-dependence, out of the self-esteem. There are so many factors which can always make a anesthesiologist to commit these mistakes. It's better to refer these patients to a higher center where all these facilities and amenities are available. And as I said, Dr. Smriti had these facilities in her institution, being in a medical college. She had a team, she had all the facilities. The case presentation was wonderful. The message goes right across the nation, even as a practitioners or even as a clinicians, whenever we encounter such case, we should not take it on ourselves, such burden, because these burdens exaggerate your life burden. Don't take up these cases. Such cases, you require help. If you have got a people around you, take them with you. Otherwise, there is no harm in referring these patients to a next higher center where the facilities are available, where the people can take care of that thing. At least you will feel satisfied that you are not taken panga with a case which was not amenable in your domain, and at least you are referred at the right time. There is no glory fighting, there is no ego fighting, no self-respected hurt here. Everything is fine. Only thing is that at least you have taken a right decision in at least saving a patient's life, because anesthesiologists, we are heading towards the majority of the decisions in saving a morbidity and mortality. People may not be able to understand at the moment because our awareness is less. But I think this case should be deferred, should be referred to a higher center. Am I right, Smriti, in that thing?
Yes, sir, absolutely. Especially in this case, if I talk about this patient had a retrosternal extension, and with a retrosternal extension, we can land into trouble anytime. So since we had the backup of fiber optic, that is why we took up this case in our setup. And sir, I would like to add one more thing. There is a term called context-sensitive airway management. As whatever the way we are going to secure the airway, it all depends upon the kind of skill, the kind of expertise, the kind of backup we have. So since we had the most advanced this awake fiber optic facility available, that is why we took up this case here.
No, I know that, Smriti, being working with me for so many years, in the previous time of years, now you are a professor yourself. I think that's a good way. Anesthesiologists being a very good species in admitting that these are their limitations, these are their powers, strengths, limitations, and we are working upon them. I think that's what makes us as anesthesiologists and lifesavers. And we are more introspective about ourselves. This case presentation is may not be that simple, but the way you present it is very simple. But Ruchi madam and Dr. Paul made it very beautifully elaborated in their comments that in such a case, how you should be going forward. That's such a beautiful case presentation, and I'm really livid about it. You did it in a very good manner, and definitely, as anesthesiologists, we should always be working toward the safety of patients rather than glorifying ourselves as anesthesiologists. We are always a director of the picture. Like Karan Johar, he's always a backstage person, but it's the person right behind the picture, the success of the movie. So that's where you are actually. So thyroid excision can be done by anybody, but in these type of cases, the role of anesthesiologist acquires importance. And one thing, this case was thought about by Dr. Manisha only, not by me. She thought about this case because she must have faced this case just nearly only, and that she thought this must be discussed about that. And you presented beautifully and managed by Dr. Paul Raffel and Dr. Ruchin Madam in a beautiful manner.
Just one more thing I wanted to add actually, when you're referring the patient, definitely you should try to procure a fiber optic laryngoscope. In a way, the management will realize the need of a laryngoscope. So actually, what like we advocate is that every institution should have a fiber optic laryngoscope. And if it is not there, we should try always to procure it, convince the management to get one.
Yeah. Thank you, sir. Thank you so much. Dr. Paul
Thank
Raffel and Dr. Neelam are always, Dr. Ruchinandan madam are always there to help us in these type of cases. Extra people.
to
Manisha madam.
continue, just to
Yeah, Neelam madam, please. Sorry
continue
for
with
interrupting
the
your.
no issue, sir. We are happy to get all our queries solved by you. So, Paul, sir, just to complete the discussion, many times we keep a tube exchanger after extubation. So, how much time we have to monitor this patient is one question, and second is if we are not sure and we are sending the patient to ICU with the tube, after how much time should we give a trial of extubation in this type of patients?
It actually depends on one more thing is depend on the duration of surgery also. Like if you are suspecting a like tracheomalacia, in the definitely you should use the tube exchanger and do the extubation part. And and since you have taken the consent of the ventilation, you can always to be on the safer side should be at the like in the ICU should try to use it. So if you ask me like when you have like how much time actually what I have like morning if you're doing this case by before before 4 o'clock, I will see to that that we will check once again and extubate during the daytime. So that's what I was practicing. We are two cases I have got in that way, and the re-intubation I have never got a case of re-intubation after extubation in ICU.
And if you are
Another
not
thing I'd
sure
like to say is, as he said, Dr. Paul said, it should be around 4 o'clock and during daytime. If in case such a thing, such a condition occurs that the patient cannot be extubated within the 8 to 9 hours, it's better to postpone extubation to the next day during routine hours again when the entire team is again present there, rather than trying to do it by the junior either PGs or junior faculty who do not have the expertise at odd hours. It's better to keep the patient on elective ventilation for another 12 hours or so and do it in the next morning.
Yes, thank you. Thank you, Tandon madam. Also, I would like to ask one more question is, Smriti madam explained that she saw the cords while with fiber optic scope while coming out. So many times the surgeons keep on insisting they want to see the cords after the surgery and we don't have fiber optic. So is there any other way? What you suggest for all these things? Do we really need to see the cords after extubation? And if we need to see, how we need to see? Because we want to extubate the patient very awake. I want the patient very awake, and then that time they want to come in and see the cords. So then I'm always struggling. So you have any solution for that?
Riti, you have been told so many times about these things actually. You can answer this.
Yes, Riti madam.
Ma'am, we can do, otherwise we can do conventional laryngoscopy. We need to keep some sedation. We need to keep the patient sedated. We can do, after giving the reversal, but continuing with the sedation, we can do conventional laryngoscopy or video laryngoscopy. If not, fiber optic is not available, we can also use a video laryngoscope to visualize the cords. Or conventional laryngoscopy was, as it was being done previously, the laryngoscope was inserted and when we were taught during our PG, we used to see the cords moving, and that's how we used to inform the surgeon that recurrent laryngeal nerve is intact.
Riti, I will
Also, you want,
I will
also
answer
you
it for
want,
you. I will answer it first. Being
yes,
Smriti,
sir.
being my senior resident, my assistant professor for a long time now, she's a professor. What we used to do as a PG students, we were told in during the early part of 2001, 2002, go for the conventional laryngoscopy. See, before the or even after the extubation, whether the laryngoscopic view is able to show you the movement of the vocal cords or not. If I ask you honestly in the house, laryngoscopy in a patient who is almost awake you know, the cuff reflex, the gag reflex, the reflexes coming to the return after gaining the consciousness. Is it really right to judge the patient's vocal cord movements in that area? Isn't it unethical to do a laryngoscopy view, putting the blade of the laryngoscope in the most vagal sensitive area and to see the movement of the vocal cord? That's the most unethical view which we were taught, but when we were PGs, I'm talking about 2 decades back. Now, with the most accumulation of the evidence, with the most accumulation of the scenarios of awake fiber optic extubations, not intubation, extubation I'm talking about. The vocal cord movement, is it secure enough that you have done a wonderful job in your anesthesia, that you have preserved the vocal cord? Isn't it the duty of the surgeons to see that the vocal cords have been working fine or they are paralyzed? Is there any mechanism that the surgeon should be taught how to see the vocal cords post surgery, that they are functioning fine or not? The questions are unlimited in this type of cases. What type of questions are being asked or will be asked in these type of scenarios? These are all based on the conventional anesthesiology curriculum. What we are going to assume in the future, suppose I'm say the recurrent RLN is being punctured by a surgeon. How are you going to blame the surgeon that you have punctured IRLN and the vocal cords are not functioning? How are you going to say that? And how are you going to establish that? Because for that, you have to have a video recording of the pre-op surgical procedure. The pre-op surgical procedure by ENT surgeon, that they have seen a vocal laryngoscopy, they have seen a direct laryngoscopy, DL, and they have seen the vocal cord functioning properly. So in these type of cases, when you are putting a laryngoscope post-surgically, it is not going to test the anesthesiologist's acumen or their functioning. It's more important toward the surgical interventions, their limitations, their misadventures, and nothing else. Because you have just inserted a endotracheal tube in the trachea, and that is never going to harm any in the recurrent laryngeal nerve or the superior laryngeal nerve. You are just pushing the tube through the vocal cord. So if you are helping these things, you are helping the surgeon. The blame should not come to the anesthesiologist that you have harmed the RLN or SLN. So while proceeding towards the establishment of these type of complications, things should be clear, should be explained, should be documented rather in these type of cases, because this is very important. This type of cases, especially in periphery. In the periphery, the anesthesiologists are always blamed for these type of things. When the vocal cord get paralyzed, they always blame that you have done something with the tube that the vocal cord got paralyzed, but not about the nerves. The nerves have nothing to do with the vocal cord intubation. So this is important. And I think people have raised hands like Dr. Surekha Chavan. Madam Surekha, you can unmute yourself. We can hear from you.
Yes, sir. Thank you. Thank you, sir. We have covered quite a lot of discussion. One point I'll add, that in such long-standing goiters, and that to having a retrosternal extension also, actually ENT surgeon also has got their role to take utmost care not to injure the nerves. And that in that case, they should use microscope during the surgeries, which in the tertiary care hospitals, they generally do thyroid under microscope. That was one point that I wanted to add. And one more, that during fiber optic is the first option when we try to intubate. But one problem of tracheal obstruction by the retrosternal goiter. That has to be kept in mind, that even if you put a tube, but in the down lower end, near the somewhere near carina, like how much extension, retrosternal extension is there, that obstruction can make some problem during ventilation. So that has to be kept in mind to tackle that, basically. Thank you,
Thank
sir.
you, sir. Thank you
I
very much.
I
Anybody
just
wants to
wanted
add
to
to
add
that?
one more thing, sir.
Yeah, Paul, sir.
The previous question, for the sake of the postgraduates, like the question was like, how can we check the vocal cords? So if you are using the monitor, the neural integrity monitor, the endotracheal tube, to a certain
Nowadays.
extent, that will definitely help. Means like it gives a sound where if they are injuring, we'll be able to know about it. And as Surega madam just mentioned about like if there is a retrosternal extension. So one thing what we see, like most of the cases they take the CT, and you should try to see the how much is the diameter of the trachea, what going down. You may be surprised to find that it will be a few of the cases you will find it's less than 4 millimeter, where you are
Yes, sir.
doubtful whether
Yes.
you are able to.
Actually, I'm worried about, because in some few next week or something, we are going to have one case whose obstruction is quite seen a lot of, but I'm worried about how we will face. Let us see how I do. We'll share that case. CT is awaited, but we see on X-ray lot of obstruction near the carina, like above the carina. I don't know. Let us see.
Once you pass the tube, what the experience like
मीटिंग
what we
असा
are,
आलो होतो कुठेतरी ते गेलं आता
what is it?
Please continue, sir.
Please continue,
Yeah.
sir.
Okay, like what we have seen is even though it is 4 millimeter, we have tried to pass the tube. Since the external compression is not very much, you tend to pass the tube, even though you find in the trachea the tracheal diameter is less than 4 millimeter. In many cases, we have seen that.
Thank you, sir.
Sir, I want to add one more thing. The problem is especially more if instead of compression, there is invasion of the trachea, like in case of tumors, malignancies. That can be a real challenging case. But when the compression is extrinsic, the literature says that we actually do not encounter any difficulty while putting the tube, which is the size of the tube, which is calculated as per the patient's habitus. So we don't encounter even a conventional, this 7 mm tube will also pass, and especially flexometallic will be very easy to pass. Yes, if we are going for the PVC tubes, we may encounter some difficulty, but the flexible tubes, they are easy to pass. The problem arises if the compression, if there is invasion of the trachea through the tube, because of the tumor, because of the malignancy. That is a scenario which is really, which can turn out to be very catastrophic also.
Malignancy, one of the symptoms actually you can get is hemoptysis also. Like where you'll know that there is chance of malignancy.
I think
thank
you.
Smriti,
thank
you've done a
you.
wonderful job in such a
Yes,
case.
Ritul.
And
Yes,
I would like to invite Dr. Neelam and Dr. Vartika to take over from here. Dr. Manisha being the program head of this case, I congratulate Dr. Manisha madam to take up such a challenging case, because this I really know it invited a good discussion, I think. And Dr. Paul and Dr. Ruchi madam had to face the ire because being the moderator of this case. So next case we should proceed forward, I think.
Yes.
Dr. Manisha,
Thank you, Bajwa sir. Actually, there are so many queries. Even I myself want to ask so many questions, but I think we have to move to the next session because of the
time is
time
limited.
constraint.
we
Yes,
can
yes,
take
yes.
one webinar only for solving all these queries.
Yes, or in the end after the second session,
At
maybe
least
we can.
we should clap for Smriti to take up such a case.
Yes, yes, yes. Well done.
Yes,
Very well presented, Smriti madam. So our next session is specially designed by Manisha madam for all these private practitioners. See, these are day-to-day scenarios where we get the patient on table and patient is having high TSH. Or patient is known case of hypothyroid since last few years, and then they are all the time taking that 100 thyronorm without any visit to the physician and coming on table for some emergency thing. And now the TSH is 12. So they always say up to 10 you give, up to 10 you give. Now what
10.
should I do?
10.
Up to up to
10.
10
Why
TS.
not 50? Why not 50?
So again, I'm in dilemma whether I should give this case.
Let's see,
or...
let's see. Let's see the discussions, how the discussions
so
come up. Okay.
just for
Sheetal madam is the first.
just for sir, just for
No.
discussion sake, I am asking Dr. Sheetal madam and Stalin sir about two scenarios. One young female, known hypothyroid since last 2 years on L-throxine, not following up with her physician, coming for appendix. Her TSH is 15 and her T4 is slightly on lower side. And one more case last week we had was 95 years old female patient for fracture femur neck, and her TSH was 55 and her T4 was on lower side. So I would like to know from both the esteemed speakers how we should go about optimizing these patients and perioperative management, how you both are doing it. We'll start with Sheetal madam first. Sheetal madam, please.
Hello, first case is young patient and
Yes, madam.
and she is for appendectomy. Generally, in young patient, there are guidelines whether we should go up about 10 or not. According to the American guidelines, there are number of studies where the cardiovascular complications and other complications where there are clinical impact of hyperthyroidism. The surgical outcome is very bad when the TSH is above 10, whatever the literature says. But if the patient is treated and stable from euthyroid up to 3 to 6 months, you can take the patient for operation.
We will go with your
Presentation?
Yeah.
Yes, madam.
Yes.
We'll go with
Okay.
your presentation.
And then we can answer at the end.
Okay. Good evening, everybody. At the onset, I would like to thank ISA National for giving me opportunity to talk on this very common topic, and we have a lot of dilemmas in this topic. That is anesthesia for hypothyroid patient for non-thyroid surgery. That is how much TSH level is safe prior to the surgery and why. So first question is, to introduce, there is high prevalence of hypothyroidism in India is reported, and almost 95%, every third to fourth patient at the increasing age we are getting of subclinical hyperthyroidism. And the significant number of patients who are undergoing surgery, they have concomitant thyroid disease. And due to the multisystem effects of thyroid hormone, the effect of thyroid dysfunction may complicate surgical procedures and post-operative. The first question is it necessary to do the thyroid function test in preoperative PAC? So, no, my big answer is no. There is no need to screen. But if there is history and physical examination suggestive of thyroid disease, then of course, yes. Then there is no history of hypothyroidism and who are undergoing treatment, then of course we have to do the thyroid function test. Additional testing prior to the surgery is unnecessary things as long as the patient is on stable dose of medication and euthyroidism was documented within the past 3 to 6 months. And especially the patient undergoing neurosurgery for cellular or non-cellular masses due to the higher risk of central hypothyroidism. Again, if there are other endocrine comorbidities with other endocrine diseases, it is and in obesity and even pregnancy, it sometimes it is necessary to do the thyroid function test. So why we are so much concerned about the TSH levels? There is a big study from the United Kingdom, and it concludes that the risk of heart disease related to damage to blood vessels is higher when TSH level increase over 10. And again, the risk of death was higher when TSH level was lower than 0.1 and especially above the 10. So these are some studies where there is increased 20-day mortality rate when there is an elevated TSH level. So what are the clinical impact of hypothyroidism on the body? It is very necessary to know. This is for specifically for PGs. There is it has great impact on the cardiovascular system. There is a decrease in 30 to 50% of the cardiac output, slowing the pulse and decrease contractility. They have depressed adrenergic tone despite of the increased catecholamine levels, and this depressed adrenergic tone causes the always develop a hypotension under anesthesia, and there will be a non-specific STV changes in the ECG and low voltage on ECG was observed. Then what about their ventilatory function? There is always ventilatory dysfunction. There may be chances of obstructive sleep apnea. They always have impaired hypoxic and hypercarbic respiratory drive. Then the enlarged lung, then swollen tissues, large goiter or obesity creates the again airway management difficult, which are great challenges as an anesthesiologist. Then there is a weakness in respiratory muscles, which again causes the lung collapse and pneumonia in the post-operative period. Then there is always hypercholesteremia and hypertriglyceridemia. And again, there is a decreased oncotic pressure, which resulted into the extracellular fluid sheet, and this decreases circulatory filling pressure and renal perfusion. There is always chances of hyponatremia in the hypothyroid patient, and it depresses sensorium and increases the effect of sedatives. This impaired renal clearance will prolong the action of all anesthetic, opioids, and other drugs. Again, it has increases hypomobility of the gastrointestinal tract. This will compound the surgery-induced paralytic ileus and delay in the initiation of internal nutrition. So what about the hematological changes? There is always a chances of pernicious anemia, microcytic anemia, and the coagulation defects. And this increases the risk of surgical site bleeding. On the other hand, the half-life of coagulation factors such as factor 2, 7, and X is prolonged. This necessitates the prolonged anticoagulation with heparin, and higher dose of warfarin for deep vein thrombosis prophylaxis is required in post-surgery. And the most dreaded complication we all know is a myxedema coma. So what are the surgical outcome and anesthesial outcome if the TSH levels are increased? So it depends upon the mild hypothyroidism, moderate hypothyroidism, and severe hypothyroidism. So you should know in the mild hypothyroidism, the TSH level are elevated, but there is a normal serum free T4. In moderate hypothyroidism, there is low serum free T4, and in severe hypothyroidism, there is always a clinical symptoms and very low levels of thyroxine T4 and pre-T4. So hypothyroidism itself a predictor of surgical outcome in elderly patient. So while dealing with the elderly patient, the targeted levels of acceptable TSH are different. And there is one study that is effect of hypothyroidism on surgical outcome, especially in plastic surgery. So they don't find any differences in the patient when the patient is treated with hypothyroidism. So in case of mild, that is subclinical hypothyroidism, it doesn't matter. That is, there will no significant differences in major adverse cardiovascular events or other outcomes as far as the anesthesia and surgical outcome concerned. But when we are dealing with the moderate overt outcome, there are higher as a safety of general anesthesia in untreated and inadequately treated hypothyroidism patient. There are higher chances of perioperative and post-operative complication. So there are 4 studies which have quoted. They concluded that in mild to moderate hypothyroidism, there are less minor chances. So there is no need that there are the chances of complication. You just postpone the surgery is not needed. So what about severe hypothyroidism? You have to treat the patient before the surgery for the elective surgery. In emergency, anyhow, we have to accept. So what will be the guidelines for accepting the TSH level that is given in my topic? So what should you accept? So there are the preoperative assessment guidelines. In hypothyroidism, the accepted level of TSH should be less than 10 for treated hypothyroidism. So what should our management when we get such patient? According to the observational data and my clinical experience, generally I am working in the institutional level. So I can accept the TSH level up to 10 with the normal T4. So, and if the patient is elderly, whatever the literature said, I can accept up to 4 to 6 milliliter international unit. And in subclinical hypothyroidism, there is no need to postpone the surgery. The full replacement dose of levothyroxine is usually given, that is 1.6 microgram per kg per day. And in elderly patient, you have to start with very low doses, that is 25 microgram daily, and with the planned increase every 2 to 6 weeks. And the dose of L-thyroxine is usually lower in subclinical hypothyroidism. So, but there are some controversial findings again with the subclinical hypothyroidism, whether we should start the dose or not. According to American Thyroid Association guidelines, they are starting the thyroid hormone treatment when TSH levels are more than 10. And if the patient, according to European guidelines, especially they recommended in younger patient when TSH levels are more than 10, and elderly patient when there is elevated TSH level. And but we have to wait and see the strategies recommended, and age-related specific reference range may be used. That is, the targeted level should be 4 to 6. Then what about pregnancy? So there are different thoughts, that is previously in pregnancy we are giving. I also think that we are the over treating the patients. Yeah, most of the patient is in subclinical hypothyroidism. Previously, there are guidelines that above 2.5 we have to treat the patient. But now recently, at least above 4, we can treat the patient in pregnant. The most concern is the mental retardation, specifically in the babies. So that's why we are over treating that patient. Then what about the pediatrics in newborns due to the developmental impaired developmental milestone? So we are treating the newborns above 5.5. So in moderate overt hypothyroidism, for elective surgery, postpone the elective surgeries till the euthyroid state is resolved. If the surgery is urgent, then you have to treat the patient in young patient close to full replacement doses. Older patient, as I already told you, which has higher cardiopulmonary disease risk, then it is 25 to 50 microgram daily. So what about severe hypothyroidism? For elective surgery, you can delay until the hypothyroidism has been treated. In urgent surgery, you have to treat the patient with T3, T4, and again the L-thyroxine. Then, but at the same time, you have to consider the adrenal efficiency, and we can add the patient with the stressed dose of corticosteroids. So there is one term called as pre-existing hypothyroidism, which the patient has history of hypothyroidism receiving chronic T4 treatment therapy. So if the patient does not take the oral treatment, then the intravenously T4 you can have to administer. So you have to give the treatment according to the severity of the disease in mild, moderate, and severe hypothyroidism. So there is one term called as euthyroid sick syndrome, where there are the laboratory findings in and there is a significant non-thyroid illness. And most of the critical ill patient in ICU, we have these findings in our critical patients. So if these patients come for elective surgery, so you have to postpone, and if urgent surgery, you have to treat that patient. Then whatever the various, as far as anesthesia consideration when we are dealing these patients. So the most common problem is difficult airway secondary to swollen oral cavity, edematous vocal cords, and goitrous enlargement. There will also always risk of regurgitation and aspiration. Then there is a hypodynamic cardiovascular system response, which is characterized by decreased output, decreased stroke volume, heart rate, baroreceptor reflexes are impaired, and intravascular volume is less. So it may be compromised by surgical stress and cardiodepressant anesthetic agent. There is decreased ventilatory responses to hypoxia, and hypercarbia is enhanced by all anesthetic agents in such patients. Hypothermia is occur quickly in such types of hypothyroid patient. There is always decreased neuromuscular excitability is exacerbated by the anesthetic drugs. These patients are very sensitive to narcotics, sedatives, and lethargics. So be cautious whenever we are giving narcotics and sedation to these type of patient. There is increased sensitivity to the anesthetic drugs. Electrolyte imbalance is always present in this patient, like hyponatremia and hypoglycemia, which requires the close monitoring. Invasive monitoring or tracheoesophageal echocardiography is needed. As far as general anesthesia is concerned, it should be a rapid sequence induction, or with intubation if difficult airway is present. Ketamine may be an induction of choice because it increases sympathetic activity and it is positive inotrope. Rapid acting non-repolarizing muscle relaxant, that is there is a potential for decreased metabolism and baseline muscle weakness. So there may be a prolonged paralysis, and there are the chances of delayed recovery in such type of patient. Anesthesia may be maintained with nitrous oxide and short-acting opioid supplementation with or without volatile anesthetic. Though the thyroid doesn't have any impact on the MAC of the inhalation agent, but in hypothyroid patient, there are the increased the myocardial depressant effect of all inhalation anesthetics are enhanced. These hypothyroid patients are very sensitive to myocardial depressant effect of potent inhalation agent. Vasodilatation in presence of possible hypovolemia and impaired baroreceptor activity produce significant hypotension in hypothyroid patient. So the pharmacological support is required. Unresponsive hypotension may require supplemental steroid administration. Controlled ventilation is recommended, specifically in general anesthesia, since the patient tend to hypoventilate if allowed to breathe spontaneously. So there are the chances of hypoglycemia. So dextrose normosaline is a fluid of choice, and the steroid coverage with hydrocortisone and dexamethasone is necessary, since decreased adrenal cortical functions often accompanies with hypothyroidism. Then phosphodiesterase inhibitors and milrinone may be effective in the treatment of reduced myocardial contractility. During the maintenance of anesthesia, particular vigilance must be paid to the signs of cardiac depression, prolonged skeletal muscle paralysis, and hypothermia. Peripheral arterial catheterization and measurement of cardiac filling pressures are recommended for the patient with severe hypothyroidism. Non-narcotic analgesic may be preferred, or these are the patients where you can use non-opioid anesthesia. So you have to post-operatively, you have to monitor fluid and electrolyte status, especially in the serum sodium. If the oral intake cannot be resumed within 5 to 7 days, then T4 should be given intravenously or intramuscularly. Then dose should be approximately 7 to 80% of the patient's usual oral dose, because that is approximately fraction of oral T4 that can be absorbed. Then developmental of non-thyroid illness syndrome or low T3, it very common in post-operative period, and the most dreaded complication, mixed coma, which you have to diagnose and treat. So I can conclude this topic. The experts' opinion are required, I think. Thank you very much.
Thank you so much, Sheetal madam. Indeed, very comprehensive, detailed talk. I think we will listen to Dr. Stallion also, and then we will discuss the topic. You can stop sharing, madam. Yes, Dr. Stallion?
Yes, sir.
Yeah, over to you.
Yeah. Am I audible, ma'am?
Yes, sir.
Yes.
Yeah. So at this outset, I'd like to thank the National ISA for giving me this opportunity to talk on this national level platform. I also thank my previous speaker for a comprehensive coverage. So as we both were talking on the same topic, there will be some overlap or repetition. So I kindly request all the audience to bear with us if there is any. So the topic given to me is very specific, like how much TSH level is safe prior to surgery and why. For that, we know why this hypothyroidism is important to us, because this is the second most common endocrine disorder. If you are coming across any endocrine patients for a surgery, this will be the most common endocrine disorder. So among the thyroid dysfunctions, the most common one is hypothyroidism. And it also is a little tricky because they present with varying degree of severity. Like as madam said, mild, moderate, severe. So we need to know how to go about managing these patients. And most importantly, this hypothyroidism affects almost all the systems in body. They have significant impact in your overall surgical outcome also. And why TSH? Because the TSH, rising TSH is the most sensitive indicator for the diagnosis of hypothyroidism. So let's refresh our knowledge about thyroid TSH hormone. It is also called as thyrotropin. The plasma level of TSH is controlled by the hypothalamic pituitary thyroid axis. As we all know, it is secreted by the pituitary gland by the influence of the hypothalamus. It's also controlled by the negative feedback from the peripheral T4 and T3. The reference ranges, it varies based upon whether it's SI units or metric units. In SI units, the range is between 0.6 to 4.5. If it's metric units, it's 1 to 18 picomoles per liter. So based on the labs, they'll give it in different units. So we need to know what is the reference range for in both the units. And we should also understand that the normal value varies with pregnancy and old age. So we should not employ the same standard values which is used for a general population also. This hormone this particular parameter not only helps in diagnosis, but also it is a reliable marker to find out whether our replacement is adequate or not. So with this brief introduction, we'll go to the questions. The first question is, why to normalize TSH before surgery? So to answer this question, we all know that hypothyroidism patients present with various symptoms and signs. We have been studying since medicine, MBBS. There are a number of which ranges from your head to toe. Lot of systems are involved. But what is of importance to us? Why should we know about these symptoms? What are the symptoms which we are more interested? So we are more interested about how this hypothyroidism affects the major systems like cardiovascular, respiratory, gastrointestinal, and what are the metabolic abnormalities, and what is of importance to the anesthetist. In cardiovascular system, there is decreased cardiac output, and because of the reduction in heart rate as well as contractility. When it comes to respiratory, there is hypoventilation, and there is reduced pulmonary response to hypoxia and hypercapnia. This is very important. These patients are likely to hypoventilate and build up CO2. And when it comes to gastrointestinal system, there is decreased gut motility, which makes them prone for constipation and ileus. It also makes them prone for increased risk of aspiration during our anesthetic management. Metabolically, they are likely to develop hyponatremia and increased serum creatinine. Though they are reversible, when we treat, they tend to come back to normal. And the most important thing is the reduced clearance of anesthetic agents, which makes them highly sensitive for all our anesthetic agents like hypnotics, sedatives, and opioids. Okay, now what happens if we don't address these problems? What is likely to happen in the intraoperative as well as in the postoperative period? Is it something very significant? Then we will address. So yes, definitely we are going to face a lot of problems if we don't address these issues. Intraoperatively, you will have hypotension, which usually don't respond to your routine treatment. There will be need for prolonged inotropic support, and they are extremely sensitive to your opioid sedatives and anesthetic agents. You don't know how drug as I said, they are likely important factors. They are prone to development during the intra period. Similarly, in the postoperative period also, these patients are likely
I think there's some network issue.
I think we should give some time to Dr. Stalin for establishing his network.
Yes, sir.
Yeah, at least 1 minute we should give him. Okay, let him establish the network.
So till Dr. Stalin is coming back, Tandon madam, there is a question in chat box. As Dr. Stalin mentioned, it is the second most common disorder, endocrine. Shouldn't it be a regular investigation? Dr. Rajesh Rao is asking, TSH, shouldn't it be a regular routine investigation for all the patients? Do you want to comment on this? You are muted, madam. You have to unmute.
Okay. So it's a valid question, but I think though it is very common, but the severity, I think subclinical and mild to moderate cases would be more in such cases in hypothyroid cases. And also, if a patient comes to you for a particular surgery, then examination clinically will also help rather than going in for a thyroid profile in every patient. I don't think that's the rule to go in for a thyroid profile in most of the patients just because it is common.
Acha, thank you, madam. Paul, sir,
Hello.
you also feel the same thing?
Hello,
Paul,
madam,
sir?
can I say
Yeah.
one?
Yes, Sheetal, madam.
Actually, there are IJA guidelines about preoperative investigation. Even that is not mentioning thyroid function test should be mandatory for every patient.
No, it is not mandatory, but what he is asking is, since it is so common and rampant, should we ask all the patients routine TSH? It is not mandatory,
Most
but
of the
should we
patient
make
is
it?
in subclinical hypothyroidism. Unless
So
and
you,
until there are no any signs or suggestive of signs and symptoms, we should not advise unnecessary investigation in pre-anesthetic checkup, ma'am.
Acha, thank you, Sheetal, madam.
Dr.
Stalin,
Neelam,
sir, you are back.
uh,
Yes, sir.
Stalin is
Stalin,
back.
sir. Yes,
Sorry
yes,
for
yes.
the glitch.
No, no
Stalin,
problem.
Stalin, we are
Please,
there for you. You
Yes, sir.
start
please
from
start.
wherever you left.
Yes.
Yes, sir. I'm not able to share, sir. Can you
Hey,
enable?
just wait. That's what I'm saying.
See and hear you.
Stalin, try to share now.
Yes, sir.
Yes, you can start, sir.
So you able to see my screen, ma'am?
Yes,
Yeah,
Yes,
please.
yes.
So I'll continue with the. Sorry for the glitches, sir.
No
Yeah.
problem.
What are the benefits of thyroid replacement? We know that there are going to be issues during the intra-op as well as post-operative period. Now, what are the benefits? The benefits from the patient's perspective, once you start thyroid replacement, there's going to be a good change in the overall presentation of the patient. But this is not of much importance to us. What is more important to us is, as anesthesiologist, is the reversal of the important functions like myocardial dysfunction, impaired response to hypoxia and hypercarbia, hypersensitivity to opioids and other drugs, the obstructive sleep apnea, hyponatremia, anemia, and abnormal coagulation profile. These things needs to be reversed, and that is what we are more interested about. Similarly, the most important thing is prevention of mixed edema. As I said earlier, we should also prevent the incidence of mixed edema coma. Now we understood that replacement is necessary. We need to do replacement, but to what extent? How much THS level is safe for any given patient? To know that, we need to know the severity of the hypothyroidism. So it usually depends upon how severe the hypothyroidism is. If it is subclinical, usually it is called when they only increase the TSH and the free 3T4 levels are normal. The TSH values will be invariably between 5 to 15 milli-international units per liter in subclinical hypothyroidism. Whereas in overt hypothyroidism, there will be increased TSH also, as well as there will be decreased free T4 levels, and patients will have clinical manifestations of hypothyroidism. In severe hypothyroidism, there will be very high TSH with very low free T4 levels. They will be always associated with other significant symptoms like altered mentation, pericardial effusion, and congestive heart failure. Now, when it comes to replacement, we should understand certain features. It's very typical for hypothyroid patients. Like most of the clinical benefits usually starts with by 5th day only, and they level off by 4 to 6 weeks. So your dosing needs to be changed only at every 4th or 6th week. You can't change immediately after a week that TSH is not increasing or decreasing, or the T4 is not coming back to normal. So if you want to achieve in a patient with hypothyroid, if you want to achieve a normal range of TSH, it may take months for you to achieve that. As anesthesiologists, we cannot wait for such a long time for the patient to be taken up for surgery. In some patients, in spite of good treatment with the thyroid replacement, the TSH may not still come back to normal. So you should think of other causes for the raised TSH. Now, coming to preoperative optimization, how we are going to go about if you come across this varying severity of hypothyroid patients. If it is a subclinical hypothyroidism, no need to start the thyroid replacement therapy before surgery. You can go ahead and proceed with the surgery. If it is, sorry, okay. Now, If it is overt hypothyroidism, you can postpone the surgery until the euthyroid state is achieved. So meanwhile, what we are going to do, we are going to start levothyroxine at a dose of 1.6 mg per kg as soon as possible, with an increase in dose every 2 to 6 weeks. So what is our target? Our target is to achieve the normal range of TSH, that is around 1 to 4 milli international units per liter. Now, if it is severe hypothyroidism and it's an elective surgery, we should not go ahead with surgery. We should postpone the surgery until the euthyroid state is achieved. If it is an urgent surgery, you cannot postpone the surgery, then you should undergo intravenous hormone therapy. Usually, T4 can be given with a loading dose of 200 to 300 mg IV, followed by 50 mg daily, or triiodothyronine can be given with a starting dose of 50 to 20 mg IV, followed by 2.5 to 10 mg every 8th hourly. When you are treating severe hypothyroidism, you should also think of adrenocortical insufficiency and to supplement with steroids also. Now that we understood, we should treat the thyroid patients, hypothyroid patients with this thyroid replacement, and we should try to achieve a normal TSH. But can we target a specific number in all the clinical scenarios? No. So when it comes to patient with coronary artery disease, if you start L-Troxin to those patients, there is a risk of precipitating or worsening unstable angina. So it is recommended that these patients should undergo CABG as soon as possible before starting thyroid replacement. This adds to the risk during the intraoperative period because these patients, without treating hypothyroidism, when you take up for surgery, they are likely to develop worsening of heart failure or hypertension, prolonged need for inotropic support, and there is going to be impaired wound healing. If at all you want to replace thyroid before CABG, there is a significant waiting period and there's patients are likely to develop complications because of that. Then you have to start with a lesser than the regular dose. Usually we start with 1.6 mg, which will roughly come to around 50 mg to 75 mg. But these patients, we should start with only 25 mg per day and also increase at 25 mg every 3 to 4 weeks if you are planning for surgery in a later part. We should also consider to give beta blockers along with thyroxine because when the effects of thyroxine will be countered by the beta blocker which we give for these patients. So when it comes to coronary artery disease patients, do not try to achieve normal TSH preoperatively. We should go slowly and try incremental dose of T4. The next clinical scenario is the pregnant patient. As Madam has already said, hypothyroidism have deleterious effects on both mother and fetus, and the reference ranges varies significantly, not only with the trimesters, but also with the number of fetuses the patient is having and depending upon the lab and the testing methods used. Usually, in first trimester, the upper limit is 2.5 milliunits per liter, whereas in the second and third trimester, it is 3 milliunits per liter. So levothyroxine should be started little on the higher dose, that is 2 mg per kg per day, to maintain the TSH at a very less level, that is between 0.5 to 2.5 milliunits per liter. So when it comes to pregnant patient, you should target a lower TSH preoperatively. Now, the other scenario where it is little tricky to treat these patients is the extremes of age. You might come across neonatal patients with congenital hypothyroidism. These patients may or may not present with the features of hypothyroidism. So when they come, you don't blindly start L-Troxin and try to achieve the normal TSH. We need to involve endocrinologists, pediatric endocrinologists, and try to treat the cases on an individual basis. Similarly, the other extreme is also a little tricky. If in old age patients, particularly above 65 to 70 years, the reference range for TSH is quite high. So their range is around 4 to 6 milli international units. So if you try to achieve the same reference range, which for a general population, you will be over-treating this patient and they are likely to develop subclinical hypothyroidism. So in extremes of age, particularly older people, target a higher TSH preoperatively. So there is another entity which is called non-thyroid illness, which we will commonly come across in most of our hospitals. These are seriously ill patients with some thyroid function dysfunction. So what type of thyroid dysfunction they will have? They will invariably have a low T3 and sometimes they will have low T4 also. And the TSH might be normal or low. Now, if you come across such patients for surgery or anesthesia, there is no evidence to recommend the treatment because it was not proven whether the treatment is going to be beneficial or risky to these patients. If it is elective surgery, defer surgery and monitor CSH. If it is emergency surgery, treat only if features of hypothyroidism are significant. Otherwise, even for emergency surgery, you don't have to treat if they are falling under this non-thyroid illness. So best way to go about this patient is you measure the serial TSH because once the critical illness starts improving, their TSH also starts returning to normal. You don't have to treat them with the L-Troxin. Now, I thought of looking into some of the guidelines, what has been recently available to guide us on how to go about patients who are on TSH. So what I could put was the most extensively published guideline was way back in 2012 by the American Thyroid Association as well as with the American Association of Clinical Endocrinologists. What they recommended is, whenever the TSH level is between 4.5 to 10 milliunits per liter, there is inconclusive evidence to recommend aggressive treatment. What if the TSH is about 10 milliunits per liter? Yes, they agreed that there is going to be increased risk of cardiovascular mortality and morbidity. So we should consider treating them. How we are going to treat them? Start with a thyroxine dose of 50 to 75 mg per day and try to reach a target TSH of 0.3 to 3 milliunits per liter. So this is way old, 2012. So I thought of looking into what is recent. So the recently what we came to know is the one of the orthopedic journal which has published an article on subclinical hypothyroidism, how it affects the postoperative outcome, and they have come out with a flow chart. The flow chart in that what they said is, if a patient has come with subclinical hypothyroidism and you are doing a TSH again just before the surgery, you find that the TSH is normal, then you don't have to do anything. If the TSH is between 4.5 to 9.9 and the free T4 is normal, you look at the symptoms. If they are asymptomatic, again, you don't have to do anything and you just monitor them annually. If they are symptomatic, you should start levothyroxine trial for 3 to 6 months. If the TSH is between 4.5 to 9.9 and if there is low FT4, then you should definitely start levothyroxine. Similarly, if the TSH is more than 10, whether it is low or normal free T4, you have to start levothyroxine. So what we do in our institute is, if any patient with subclinical hypothyroidism comes, we take up for surgery. We don't start them on thyroxine and wait for the TSH to come back to normal. But if it is a moderate hypothyroidism, then we decide on an individual case-by-case basis. We involve the surgeons as well as the endocrinologists. We talk to the surgeons how long they can wait, and we discuss with the endocrinologists what will be the best TSH value. Based on that, we take a call when to go about for the surgery and anesthesia. So we should analyze the risk and benefit. Should waiting for the surgery will do more harm to the patient, or aggressively correcting the TSH will do more harm to the patient? So those things we should weigh, and accordingly we should take a call. So frankly telling, if you ask me personally, I don't target any specific TSH levels. Even in cases of moderate hypothyroidism, I handle them in a case-by-case basis, involving my other team members like surgeons and the endocrinologist. When it comes to severe hypothyroidism, I don't have any personal experience. In my 15 years of experience, I never come across a patient with a mixed edema or severe hypothyroidism coming for emergency surgery, and I never used intravenous Keltroxin also. I'll be very happy if any of the members of the audience can give us insight onto this. Thank you so much.
Thank you, Dr. Stalin. In spite of all network glitches, the flow of your talk was not interrupted.
Thank you so much, ma'am. Sorry for the network glitches, ma'am.
No issue. That's what I'm telling. The flow was not interrupted at all.
Dr. Stalin?
Sir, yes, sir.
Myself, Dr. Manoj Kumar, Treasurer, IS National. One question from my side.
Yes,
what
sir.
are the effect of healing process if the hypothyroidism present, especially moderate to severe degree of hypothyroidism?
Sorry, sir, I'm not getting you.
Healing process.
Healing
what
process.
is
Excuse me.
effect of healing?
Stalin
Healing
sir,
is
can you
impaired,
stop?
sir.
Can you stop sharing, Dr.
Yes,
Stalin?
sure, madam.
Yeah.
Yes, ma'am.
Manoj
Yes,
Kumar sir, you were asking something?
Effect on the healing process after surgery. What are the if patient is hypothermia, especially moderate to severe level?
Yes, sir. So not necessarily the patients should be on moderate or severe, sir. The healing process will definitely be impaired if you take patients for hypothyroid patients for surgery, sir. So we have to prepare ourselves for delayed wound healing. There is no other go, sir. Yes, it's going to be there, sir.
Okay.
As I said, if it's an elective surgery, we can wait for the TSH to come back to relatively normal levels. Otherwise, if it's an emergency surgery, we should prepare ourselves for the delayed wound healing, sir.
Okay, thanks.
Thank you, Dr. Stalin. Paul sir, you are there? Tandon madam?
Yes.
Yes, Paul sir. After now this comprehensive talk on thyroid. Now tomorrow we are going to go and see this patient of appendicectomy with TSH of 15. So now how should I tell the relatives what is the issue and how I'm going to deal with it? So how should we explain the relatives that in spite of all these things, we are going to go ahead with the surgery?
Okay. So appendicectomy being an emergency case, you will have to explain the possible issues which can come which we can face in this situation. And Dr. Stalin and Dr. Seedal has nicely told about the protocol, how to proceed and do the case. The main thing is the communication, what you have to tell. Now, you have to see what type of, as they have already mentioned, what type of, what is the type of hypothyroidism. So he said about the subclinical you not go. And the range what Stalin has mentioned is up to 15, which I doubt actually whether it's my mistake or what are in my memory. It is actually in 10, 5 to 10. You should take it as subclinical, and always it is said that about 10 definitely there will be a myocardial depression, things like that. So we have to rule out what type of hypothyroidism the patient is having and should be proceeded.
There is a question in chat box, Tandon madam, how old TSH we should accept the report? You have to unmute, madam.
If it depends on the case. Basically, case by case, if the patient is showing signs and symptoms, you feel that the patient could be a case of moderate or severe hypothyroidism, then you should ask for a fresh report. Otherwise, I think in case of subclinical or mild this thing, for a thyroid function test, you don't go in for a fresh. You don't, in fact, ask the patient to go in for this TSH routinely also. So I think it depends on the patient's the clinical how you see the patient, how the patient presents to you, and that is how you go about it. I
Thank you,
haven't come
madam.
across any guidelines.
I know sometimes I've seen the patients keep on taking Thyronorm and their TSH is less than 0.1. So they don't take any physician reference afterwards. Such patients also we have seen. So means how old report can we accept? That's what I want to know. Paul, sir, you have any comment on this?
Yeah, it depends actually. If you have if the values are within the normal limits, definitely you need not go for it. And if the treatment is in the right way, one thing I just wanted to add in this is like we have to see whether this is seen by an endocrinologist. Like you have the facility of endocrinologist, because many of the doctors are treating this hypothyroidism or hypothyroidism. And like recently, what I understood is that for both these drugs, actually the antithyroid drugs and the other one is given simultaneously. There is some regimen they were talking about. Like the surgeon, patient recently we operated, he was saying that what I found out that both these drugs, both are given actually, even the beta blocker is also given. So those things actually, then what I did was I sent that patient to an endocrinologist. So you have to remember that a proper endocrine checkup should be done for these patients.
Vartika madam, any questions from the chat box you want to add?
Yes, I was just looking for that. Someone has asked, is IV thyroxine available in India? I think
I have not used it, but anyone has used, sir?
And
Anyone
going
from
to
the audience?
First thing, it is available in India or not? That should be answered. I am also not sure.
Also, for the previous lecture, many people have commented about using sonography to see the cord movements, and that is
USG
actually
for cord movement, it can help
after the surgery
after the surgery.
instead of using.
Even CMAC is very good for looking the cords rather than putting a laryngoscope.
Yeah, any video laryngoscope for that matter.
Bajwa sir,
What,
you want to
what I
add something? Bajwa sir? Yes, sir.
relate to that thing. You see, sonography, what we usually normally do in the OT or the ICU is a 2D, two-dimensional. That means you are
Then
getting
post-operatively while using, because there is a
whatever,
sticking.
madam, whatever,
So you don't have to.
post-operatively or the pre-operatively or intraoperatively, we are using 2D normally because we have got a PNDT Act where we hardly move the USG machine from the radiology department to the ICU or to the OT in many states. The problem with the USG is that now with the advent of technology, we have got a 7D ultrasound also. But the 7D ultrasound has got a strict paranorm that they cannot be shifted out of the particular area, nor cannot be even moved by 1 meter. 1 meter I'm talking about. And whatever the results I've seen with the 7-meter, the 7D ultrasound, they're absolutely truth from front skin to the back skin. They can scan the whole abdomen, thorax, whatever you want. But the only problem is that they cannot be moved from one part of the scenario in the OT to the other part of that. That also depends on state to state, the permissions also. Now, with the vocal cord mode, we are trying to answer the vocal cord movements here. How can you assess the vocal cord movements in the 2D ultrasound? Only two-dimensional, the vocal cord movements actually. If you go with the dynamic movement of the vocal cord, it's not two-dimensional. They just go sliding, they just go in that manner. When the vocal cord, the cusp closed, they make a good reservoir that nothing should go to the trachea. So if that 2D ultrasound is good enough to gauge the movement of the vocal ultrasound, the movement of the vocal cords, that I don't think so. That's correct itself. Ultrasound is not the safest measure to assess the movement of the vocal cords. Either we should have a 3D or go beyond that to assess the movement of vocal cords. And that's where comes the role of an ENT surgeon. Why we always call for a thyroidectomy patients, a ENT surgeons, pre-op investigation, a pre-op movement of the vocal cords, because when they see the vocal cord movements, it's not just the movement, whether they are, what you call them, opposing each other or again away going each other. So the ENT surgeon gives a clear phenomenon because they see so many aspects related to that the vocal cord movements in that particular direction. That report is also very much important for the medico-legal purpose, as well as for the surgical purpose, as well as for the anesthesiological purpose also. Because many times you people are blamed that for that the vocal cord palsy is there, you inserted a tube in such a manner that you have inserted a vocal cord, you have inserted a vocal cord palsy. How can you do that? You have just touched the cusp of the vocal cord, not the nerve. The nerve is always touched by the surgeon in the surgery, not by the anesthesiologist. Remember that. So remember that you are not the culprit in that. You are doing the intubation according to your equipment, according to your assigned task, that you are doing the intubation in that particular manner, in particular position, and in a particular juxtaposition, that what is the size which you want to insert as a tube. It's a 7, 7.5, 8 or 8.5. In the adult patient I'm talking about. So the vocal cord injury mainly occurs how? You should understand the pathology when thyroid surgery is being undertaken is either by the superior laryngeal nerve or it's a rectolaryngeal nerve. And tell me, how many times an anesthesiologist touch these two nerves? They never touch these two nerves during intubation. So where they are responsible. But every anesthesiologist make it sure, even in the practice, when you are intubating such a patient, in the practice also, forget about the ENT presence or not. You see when you are doing a direct laryngoscopy, whether you are able to see the movement of the two vocal cords simultaneously, they are closing or opposing each other or not. That's the most important part of the laryngoscopy. Because without giving scoline, without giving atracurium or vicuronium, try to assess the vocal cord movement even with a propofol or thiopentone or etomidate, whatever induction you are using. That's the best way to go forward because in these circumstances, you will be able to assess whether both the cusp or the vocal cords are opposing each other or not. Once you paralyze the smooth muscle, the skeletal muscles, both muscles are going to be, whatever you say, scoline is going to go skeletal muscle. No. Sometimes smooth muscle also going to paralyze to some extent. So see the movement after the scoline, see the movement before the scoline, try to document that in your chart, whether in your practice or in institution. This is the moment. This was the moment I perceived before induction. This is the moment I'm perceiving after induction. Write simply that. So no anesthesiologist can be incriminated in any of the medico-legal case in that. That's my take, my experience over the years. And even my ENT surgeon also agrees to that every time they see that anesthesiology is the best person to assess the movements before induction and after induction. Because after induction, we are giving the case to the ENT surgeon directly. So whatever they are going to perceive, it is your case now. So that's my request to every anesthesiologist. Try to assess the movements before induction and after induction. Or if your ENT surgeon is very helpful, try to take his opinion or her opinion before operative surgery, before during the PAC with the ideal direct laryngoscopy. All the movements are there. That's a very simple message to everyone. That's my take. I think there are many learned people here. They can also give their opinion also in these type of cases.
Thank you, Bajwa sir. Indeed, very detailed explanation of this vocal cord and how to see the movements and all. Manisha madam, with your selection of this topic, I think this discussion is going to go on and on. We would like to have your comment, please.
No, it was excellent discussion, but I think what we missed in the discussion regarding hypothyroidism is the ECG changes, because many a times I remember that looking at the ECG, the low voltage ECG itself is a diagnostic, especially in a patient with subclinical hypothyroidism. So your pre-anesthetic checkup should be very perfect. Patient gives this, I usually deal with neurosurgical patients. So patient coming for spine surgery, the relatives and having quadriparesis or maybe weakness in lower limbs, the relatives gives you a history that the patient is dull over last 2 months and he's feeling lethargic. And if you see a low voltage ECG, see, we all discussed about the hyperthyroidism and hypothyroidism, which is already diagnosed. But what about the patients who come to us who are yet not diagnosed as hyper or hypothyroidism? So our pre-anesthetic checkup is very important. Few history as well as the clinical finding give us an indication to send their T3, T4, TSH, and that is very important because if we anesthetize these patients with may not be subclinical hypothyroidism, maybe the value between 12 to 14, and in these cases it is very difficult to explain later on that we missed diagnosing hypothyroidism. So it is also our duty to find out the subclinical hypothyroidism patients in our preclinical assessment. That's what I feel. It was a wonderful discussion. I think Dr. Parna has raised her hand. Dr. Parna Thakkar.
Yes, ma'am. It was a very nice discussion. And I just want to add that sometimes quadron can have effect on thyroid levels. So if a patient is on quadron, then we should definitely do TSH levels or T3, T4 TSH, because quadron is very, very lipophilic. So either it can increase or decrease the thyroid function, and that has to be kept in mind.
Yeah.
Thank you.
Yeah, Dr. Parna, that's a very right answer. Actually, I was going to discuss about that also. It's not just the level of the TSH or the T3, T4 or free T3, T4. Amiodarone has a good effect on other antihypertensive effects also. So what antihypertensive you are going to oppose? So a patient may be having a hyper or hypothyroidism, and you are going to initiate some hypertensive. So you have to see, because many of the antihypertensives has got direct interaction with the thyroid hormone. So that is very important. So here comes the role of the physician. I think our every anesthesiologist who are working in the ICU or who are working in the latest medicine also, they know that amiodarone or cardarone, whatever is the drug you name, they've got a very much interaction with the thyroid hormones. So you have to choose a very precisely, judiciously the antihypertensive agent in the case of hypothyroidism or hyperthyroidism. Thank you, Dr. Parna. It's a
Yes, sir.
good gesture. Yeah.
Thank you, sir. Yeah.
Anisha,
Any more
madam, over to
questions?
you.
Yeah. Any more questions in the chat box? Dr. Neelam, Dr. Vatika?
So I think most of them are covered, madam, in the discussion.
Yeah, definitely it was a wonderful discussion on both the topics. Our chairpersons, Dr. Paul Raphael and Dr. Ruchi madam has done a wonderful job. And of course, the presentations by Sheetal, Stalin, as well as Dr. Smriti, they were wonderful. And we have to do important job. And to Dr. Bajwa sir for the most important job for today's evening.
अरे नहीं important जो पता क्या है अभी भी लोगों को we should invite people who want to ask questions actually we have not
okay yes
give them an opportunity to ask the questions actually.
Sir, have you used intravenous L-thyroxine?
Intravenous
Thyroxine IV
अरे मुझे देखा जिंदगी में देखा नहीं मैंने आज तक तो कभी आपने देखा क्या
I think Dr. Mohan Patak has raised that query, but even I don't know. We have to find out.
Madam, please.
Sir, it is just given in the books.
Mohan Patak is a very regular.
It is given in the book. That
it
is
just given in the books. But I
once
I tried to find out what the trade names were. I tried to contact somebody whether it is actually available. But I don't think it is. I'm not sure about right now.
But it's a treatment of eczema coma, na? You have to give in this.
You have to give, but I don't know whether it's actually available.
Many of us must not have seen a patient of myxedema coma.
We have not seen.
Hello.
Anybody has seen?
Anybody has?
Excuse
Yes,
me.
yes, ma'am.
Dr. Mohan Patak.
Yes, ma'am. Excuse me, ma'am. There's one question, ma'am. If a patient is posted for lab cholecystectomy and she is having TSH of suppose 9, should we go for TPO and antibodies or not, ma'am? Is there an indication?
Anyone can answer. Any chair there.
Hello.
Faculty chairperson. Anyone can answer.
Yes.
Will you please repeat your question, please?
We didn't understand the question. Yes, please repeat.
Yeah, ma'am. Suppose a patient is posted for lab cholecystectomy or some lab cholecystectomy, ma'am, and she's having TSH of 9, suppose. Should we go for any further investigation to rule out the thyroiditis or for TPO antibodies or not, ma'am?
Only TSH is done. T3, T4 is not
Only
done.
T3, T4 are within normal limit.
Within normal limits. Yes, Dr. Paul, you want to take this question? Should we go ahead with the case with
I
TSH
think
of
this was already answered. Like you have to see whether it is subclinical or not. And 9 is one of the safe parameter. You have to rule out.
Dr. Paul.
Yeah.
It's my personal question. He's saying around 9. I say 59. So what do you say about that? T3, T4 normal, clinically normal, no symptom of any thyroid. TSH is 59. So what do you say about that?
Definitely, I will not do. will not do the case.
So, sir, that our next case, second case of fracture neck femur was same, 55 TSH.
But
We
madam,
have
it is
to do
emergency,
na?
na? It is
Emergency we
emergency.
have to do
In
na?
regional anesthesia, we can.
Well, so see, we
See,
anesthesiologists.
one of the wrong assumption many of the have is
Dr.
regional
Paul.
anesthesia.
No,
Regional
we have to
anesthesia,
see
yes.
all the.
Dr. Paul, I'm
Yeah.
saying when we are ready to take up a case of 59 TSH in emergency setup, taking up all the challenges that anesthesiologist is doing to handle all the dirty work. And we are not going to take up more than 15 in the or 10 or 15 in the normal elective cases. So how does suddenly the anesthetic management changes from 15 to 59 or 60, whatever it is? Why can't we take up a 60 TSH case when we know the T3, T4 are normal, patient has a euthyroid status, patient is clinically normal, and the metabolic enzymes which are going to catabolize the TSH are not normal in the human being. Many times it happens like that. The TSH remains higher until and unless we introduce some anti-thyroid drugs or whatever. The TSH is it a TSH a independent marker or risk stratifier postpone a surgery without any clinical overt syndrome? Because I think the TSH molecule is available in the blood. You say it's a 55, 50, 65. But is it an independent marker for postponing of the surgery with a clinically euthyroid patient? Clinically relevant T3, free T3, free T3, free TO for normal range. Patient doesn't have anything. Is it due with the molecular mechanism where the TSH is not being metabolized or not being broken down to a level so that it should be brought to such a level which is available according to the protocol set up in our chemistry, in the biochemistry or in our history, that the TSH level should be such a low that we can take up a surgery. I have taken up a case in the 100 plus TSH with a normal T3, T4, normal euthyroid, no clinical functioning. The whatever the Lancet, BJA, anesthesia, analgesia, anesthesiology, whatever journal they say the TSH level, I'm telling them again and again, I can write a letter to them that TSH is not an independent marker for deciding a case of a surgery in where the thyroid levels are being estimated. You have to see the clinical profile of the patients. That's more important because the TSH levels are independent biomarkers. They are not the risk stratifiers. They are being metabolized according to the patient's own hormonal chemistry, their metabolisms, their status, their endocrinological status, or the level of TSH is how it is going to affect the hypothalamic pituitary axis deviation. I'm very much open to that. Why the Britishers and Americans can all have all the research on these issues? Why can't we? I'm telling again and again to this open forum because these type of things are open for discussion when the private practitioners are being the part of this forum that a TSH level is not an independent marker of any surgery. It is just a biomarker that your T3, T4 are not normal. But when the T3, T4 are normal and TSH is elevated, that means the problem lies somewhere else. The problem lies in the hormonal mechanisms, the degradation, the biodegradation of TSH. There are so many issues to be discussed here. It's not a business journal, it's not anesthesiology, anesthesiology or Lancet. They may not be knowing about these things. They may have got advanced infrastructures, advanced equipments, but I'm telling you, the day they say, the day they declare here on any forum, even the WFSA forum, that TSH is an independent predictor and the risk stratifier for any surgery to be undertaken, I can say they are right. But to me, what I say, the T3, T4 is normal. The free T3, T4 is normal. The TSH is not metabolized because our species, the tropical country species, don't have those hormonal competencies and efficiencies in metabolizing the TSH. It's metabolite. What metabolite we are estimating? We can just have a one metabolite estimation in the laboratories of our country. They are estimating TSH according to the whatever they call, you call say metabolite estimator for the last 15 years. We have not modified our biochemical profile in our country. TSH has got at least multiple metabolites. Whatever is it active metabolite? Is it inactive metabolite? It's a partially active metabolite. However, we are estimating TSH. Nobody has ever derived that equation. Even if you ask an endocrinologist, we can have an open forum discussion with them that TSH is never estimated properly in our country. Is that TSH is going to happen, is going to affect our T3, T4 molecular pharmacology, molecular secretion from the thyroid? Is that an active metabolite? Is going to have? Is it a direct secretory from the hypothalamus that is going to affect the thyroid stimulating hormones effectively, going to those receptors? So there are so many biases, confounders, and things which are directly to be answered. That's why this seminar is particularly, taken for, because in real practice, I've seen people with 100 of TSH, normal T-thyroid functioning, normal thyroid functioning, undergoing surgery, wondering, coming out beautifully from the surgical procedure where TSH doesn't have a role. So ultimately, what we are going to do is, in this discussion, is that, is TSH a real determinant of our surgical procedure, or just a hypothetical dilemma that we have to postpone our surgeries? Because in many situations, the TSH crosses 10. Oh, postpone the surgery. The TSH is high. Does it really affect the patient's caliber, patient's morphology, patient's everyday living status, or patient is going to have any dire consequences because of high TSH? It's not like that. A patient may have a high TSH as 100, but the patient is having a normal life in spite of 100 TSH, because that 100 TSH is estimated by the biomolecular mechanisms, estimated by the laboratory mechanisms, not by the metabolite, which is going to affect your T3, T4 secretions, or which is going to affect your thyroid secretions or thyroid functioning. So many effects are there. So I think it's a high time we should have a research on these issues. We should have a practical issue on this research, whether the TSH, whatever you are estimating, is a real determinant in deciding about the surgical factor. That's my take on these issues.
Thank you, sir. Thank you so much for such a wonderful.
Yeah, definitely. We should, in fact, we should present all of us should do what we should do. We should publish cases which we have done with high thyroid levels, high TSH levels, and we should, that will also be helpful to find out the data on this. There are two more questions, two more people, Dr. Madam and Dr. Mohan Pathak, they have raised their hand. Yes, madam.
Can I say, madam? Yeah.
Yeah,
I
please,
had come across one patient where hysterectomy was to be done. Like sir said about the T3, T4 normal, but but only the suspicious was her ECG. It's a 1 or 2 millimeter that height was the ECG. So I asked my husband, this is a low voltage ECG? Should we do TSH? And then I found the TSH was 100. She was a thin lady, 30 kg for hysterectomy, asymptomatic. But in that case, if I had to, of course, postpone because no thyroxine IV is available. But in that case, like suppose, as the sir said, like this is not the only biomarker. Only suspicion was or low voltage ECG. So that shows that definitely cardiac problem would have occurred if I had gone ahead with regional anesthesia. Like hysterectomies are generally done with regional. So I had to postpone, but this low voltage, and they definitely show some symptoms. I mean, signs and symptoms, not symptoms, but these are the clinical findings on ECG. So what could have been in that case? What could have been my role? I mean, my strategy in that case? Of course, I postponed the case, but what could have been a better way of managing that case?
Madam, this was the patient which was not a diagnosed case of hypothyroidism.
No, she was not diagnosed.
Yeah, so it is
It's
you
an
who
accidental
have
finding.
mentioned.
Huh.
Yeah, so it is because even I remember doing 4 or 5 finding 4 or 5 cases of patients who were diagnosed just by looking at the ECG. Patients then on leading questions have answered that yes, they do feel lethargic or they do feel dull, like the history which I got. So when such cases are there, it is always better to go ahead with T3 and T4. Consult an endocrinologist, take an opinion, assess the patient, fully assess the patient as far as the cardiac status is concerned, and then only you can go ahead if it is an elective surgery. That is my take on this.
Yeah, that was an elective case, of course. Yeah. I did not. So when I told her to do the further profile, like she managed. She managed.
Dr. Shobha, Dr.
Yeah.
Manisha and Shobha, I will just
Yeah.
ask one question.
Yeah.
Suppose the TSH is 80, T3,
Okay.
T4 normal, patient is clinically asymptomatic. How much time you want to give to the patient to come
Sir,
to
but
the...
that patient is having low voltage ECG.
Low voltage ECG.
That's
So
what
there was
I'm
some
asking.
cardiac.
How much time you want to give to that patient?
Sir, it is elective case, so we can wait for
Elective
3
case.
weeks.
Now,
3
how much
weeks.
time you think you
I don't
should
think,
give?
I don't think
No, no.
that the TSH will come to normal within 3 weeks, but at least
That's
start
what
that
I'm
patient
saying.
on.
That's what I'm saying.
Yeah.
80 TSH, T3, T4 normal.
Start the
Patient is
patient on
clinically normal.
antithyroid, sir. Yeah.
No,
So
one thing
how
I
much
want
time
to add to this
Shobha,
is like it depends on like whether the patient is taking medication or not. Whether
the
the
medication
patient is
normal,
having
with the
hypothyroidism and taking medication, then the TSH change will be much slower. TSH change will be slower if the patient is taking any medication.
Yes, that's what I'm trying to say. The TSH metabolites, the TSH level, our laboratories are sensitive to a particular TSH molecule. The TSH may be having 100 molecules to be assessed, but our laboratories are sensitive to 1 or 2 molecules in which they assess the TSH level. Actually, what happens, the TSH level, which is the most active, is not clarified in our laboratory sciences, even our microbiological sciences, which is the TSH most active, that they should pick it up, that this is the most active metabolite of TSH, that this level should be less, because they take it as a compensatory TSH mechanism. When a laboratory mechanism pick it up, it's about the molecular, they just color it that this is the TSH level. And how much that TSH molecule really affects the T3, T4 secretion is not determinant upon the quantity. It's a qualitative assessment of
Sir,
TSH.
should I enter like any other hormone? There are assays. So is there any assay?
Madam, एक minute complete करने दो. The TSH qualitative assessment is very important, which should come into the purview of our microbiological and pathological assessment, that this is the molecule of TSH which should be assessed before undertaking any surgery, because this is the real molecule which is going to affect the secretion of thyroid hormones, whether T3, T4, in a crisis situation. Suppose after surgery that this much of thyroid T3, T4 is necessary for the recovery, but the TSH is not adequate to at least get the recovery molecular to that level. So TSH level, which is good enough to get a that recovery of thyroid hormones. That means that TSH level, which is very active, the very active metabolite, there are maybe 100 metabolites. I don't know which metabolite is being picked up by the which test. So, because our tests are very rudimentary, we have not modified our tests about the real TSH. The TSH may come in many forms. If you go about the molecular pharmacology, TSH can come in many forms. It's a partially responsible, it's a completely active, completely inactive. So many forms of TSH are there. So first of all, we will identify that this much of TSH is active, this much of thyroid hormone we require for the surgery, and these are the levels we should go for the surgery, elective or emergency surgery. That is my take on this thing, because our science, whether in European or American or Indian sciences, the TSH levels to till date are not actual determinant for the risk stratification of any surgery.
So my
That's
question, is there any hormonal assay like any other hormones regarding your TSH? And then we can, they can find out how much is active and inactive. It's just like that.
Madam,
Is there?
see, we CFC men syndrome. Men syndrome 1, men syndrome 2, men syndrome 3. Because in daily life, we see so many syndromes together. The reason being, so many endocrinological systems are interconnected. With thyroid, there are so many systems interconnected.
Yeah.
It's not we that get a thyroid patient independently. If you go in depth, you will always find some variability in other hormonal mechanisms. That is for sure. Independent thyroid mechanism disturbance is very rare, very, very rare, even if it is encountered. But here we are talking about the TSH levels. The discussion is about the TSH levels. I still say the TSH levels of even 100, how does it going to hamper your surgery when T3, T4 are normal? The thyroid status is normal. The patient is clinically euthyroid. Is the TSH independent level a risk determinant for any surgery? Or is it going to cause any crisis during surgery or post-operatively? That's my question to the esteemed speaker, Dr. Sheetal Dalal and Dr. Stalin. Because these are the questions we face every day in our life. In practitioners, I've seen a patient being operated for 200 TSH with a normal T3, T4 without any post-operative complications. I say this is not a good way to present my case, but with the evidence, not in the favor of higher or lower TSH. You go with any studies in the Lancet or in any journal, the TSH levels, are they really the truly independent biomarkers for any study? Are they really going to interrupt you for any study or a surgery? Are they really going to hamper the results? Are they really going to impact the prognosis or even the result of the surgery? So these are my independent questions to our esteemed speakers, Dr. Sheetal Dalal and Dr. Stalin. Dr. Mohan Pathak has raised some questions. Let him first answer, then we can move to Dr. Sheetal and Dr. Stalin.
Dr. Stalin, can you unmute?
Yes, sir. Sorry.
Hello.
Dr. Mohan Pathak is
I'm
there.
just, sir, I just wanted to tell about the incidents. Once we operated neck swelling under general anesthesia, and then patient complained about the hoarseness of voice or very bad quality of voice. And
Sir,
he filed
sir,
the
your
case
voice is
against
very low.
surgeon.
Sir, be near the speaker.
Yes. So we had operated one neck swelling. It was not thyroid. And patient developed hoarseness of voice or low quality of voice. Voice is gone, he was complaining. And he filed the case against the surgeon. But surgeon was, as you said, he was doubtful about the intubation, which was not at all problem. And later on, it turned out to be a neural swelling, which may be the victim in that case. So we have to be always cautious about the noting his quality of voice pre-op and to mention in our pre-op examination. He actually filed the case and surgeon has to face the litigation. Just because of the small neck swelling he operated, and then patient developed hoarseness of the voice. Yes. Okay.
Dr. Sheetal and Dr. Shalin, take over from here about the important discussion points all. And
Yes.
Dr.
Hello.
Neelam and Dr. Vartika, you keep on asking the question in the chat box, please.
Yes, sir. Yes. Sure, sir.
Yes, sir. Yes, sir.
Sir, I would like to give my opinion, sir. I completely agree with your opinions. Even I do practice what you exactly said, sir. Like if a patient's free T3 and T4 are normal and the patient is clinically euthyroid, I don't care about what is the TSH value, sir. I have done many cases, as you said, with higher TSH values and they came out nicely. The only area where I face problem is that to make them clinically euthyroid. Like when a TSH is very high, you need to be very careful to make sure that they are clinically euthyroid. We have to do extensively investigate this patient, get an cardiologist opinion, get echo done. So that one part we can do if you get severely high, very high TSH values. So otherwise, I completely agree with your view, and that's what we practice also, sir, in our institute.
Even you can involve endocrinologist while dealing with this case.
Sheetal madam, your anything points from your
Sir,
side?
whenever I am preparing this lecture, I found just this in the review of literature, I found some studies where not that hypothyroid that TSH level is a predictor in elderly patients, especially elderly patients, sir. Elevated TSH for surgical outcome. There are 2-3 studies they have done. One study they have done for 22 years, and they have studied for that TSH level for the cardiovascular effects or any adverse effects in these patients, in cardiac patients and treated and
Definitely,
untreated.
definitely.
Personally, I don't have experience. Huh? Whatever I found in literature.
One question, very
More
challenging.
research is required, sir. Whatever I.
Yeah, that's what I'm saying.
More
A
research.
Very challenging question was there. Are
Even
there any
when I have, sir, one
Indian
thing,
guidelines
even
about that?
pregnant patient, they are over-treated due to the mental, to prevent the mental retardation in the babies.
Madam,
Yeah.
see, there was a same question in the chat box about the Indian guidelines. I say 92 participants are there. You subtract 10 of them, speakers and moderators and presenters. 82 participants are there. I invite every one of them to send a proposal to me on isanhq@gmail.com. How we can proceed towards the guidelines of this issue. Because see, after every crisp or clip series, we can always come to a conclusion that we can formulate guidelines or Indian standards. But it depends upon the initiative. You can't depend upon me. My area of work is such a that I cannot make everything independently. Everyone has to help me with Dr. Manisha at my now with my side. So she being my co-director of this classes of these webinars. You send us a suggestion, send us a query, send us a whatever the proposals for formulating a guideline to these type of things because these guidelines are not there in literature, not even in any of the world forum. And we Indians, think we are always comprehensive that we are not the first one to start these things. Maybe people have formulated one. No, try to form something because we were the first one to form the COVID guidelines and they were published on the WHO website. So why can't we formulate guidelines on these type of classes issues? The only thing is the people have to forward their consensus, their consent, their initiatives, their suggestions on a particular email. We'll move forward because the discussion will be never ending. What Dr. Sheetal Dalal, Talin, and Simriti have done today, they've done a wonderful cases, wonderful presentation. But I think even after the end of these discussions, we are still in dilemma how to go about that because there are so many conditions, so many perioperative scenarios where the management changes, where the things changes, where the dynamics changes. So many things are there. Even the TSH level, you know, that level, I say somebody getting a surgery done at 150 level, somebody getting it at 100 level, somebody getting at 50 level, and still the patient are safe. Do you think the Western guidelines are good enough? No. The Indian guidelines can be more robust can be more robust, can be more authentic, provided we have a real evidence-based guided formulation of guidelines. And with this type of seminars, I request everybody who are the speakers, the moderators, to come at least with the, because whatever the group we have found on the WhatsApp also, come out in the group something. We involve everyone. At least there is no dearth. We are starting the new journal. In the new journal, I think we can always have one section for the guidelines, especially these type of guidelines for the thyroid stimulating hormones, the T3, T4. Whatever discussion we had today, we can always formulate, we can compile it, we can come out with a discussion over it. And I assure you, I can really assure you what Dr. Paul, Dr. Ruchi, Dr. Manisha had discussed in this forum. This is much, much better if you can discuss these things on an international forum. The only thing is that we Indians should not be bothered about these things. We are we having a platform. The volume of the cases, I think in Kerala, in Maharashtra, or anywhere in the country, we have the highest volume of cases. Whatever the evidence we are having, we can have that much evidence. The only thing is the initiative. Initiative we have to take. I request Dr. Manisha to form a group for the guidelines for this thyroid surgeries. Because myself and Madhuri, we had a chapter in that Lee synopsis of thyroid surgery. That is the first book where all the Britishers had the chapters. We were the first Indians to have a chapter in that. So why not we Indians come up in these things? So Dr. Manisha, form a group, take a speakers and proposers from this group to form a guidelines and come up with a proposal 8th of June at Chennai. So we'll formulate a group for these guidelines, and we can come up with Ruchi Tandon madam and Paul Raffel sir as one of the pioneer in this type of guidelines. Our speakers also, you and all the eminent personalities here, that those thyroid guidelines will serve as a mirror for the entire world, because we have the highest volume of the patients in our country. And in Tamil Nadu, in Kerala, in Madhya Pradesh, in Chhattisgarh, in Northeast, in East, in Central India, in the North, you have a different subset of patients. We have got a different subset of culture, different subset of practices and outcomes also. We will come out with those things. This is my request to you, to everyone in the house. We can make a group about that. We can come up with a guideline about this case, particular case. And Vartika and Dr. Neelam Nalge, they will be the anchor of those guidelines also, with those there also. So it's my request.
Yes, sir.
Dr.
I'll get the proposal.
Okay.
Yeah.
Please,
Okay.
this is a priority. This is a priority because in our tenure, Dr. Manisha, you and me and we are together in this tenure next 1.5 year. We try to make maximum guidelines on the issues which are controversial, which are not better understood by anybody. Because TSH level today also, after the end of discussion, nobody is sure what level is safe. Not the academicians, nor the practitioners, nobody knows about it. But ultimately, we have to undertake the surgeries for those patients under without any controversy also. Without taking, say, the anesthesiologists are the deciders in these things. But as a clinicians, we have to take so many factors in consideration while taking those patients for undertaking the surgeries. So I request Dr. Manisha to undertake this proposal from my side.
Sure. Sure.
Come out with the guidelines on this issue. This is a very important CRISP series. Today, path breaking. Thank to Dr. Paul and Dr. Ruchi madam. They have taken a special effort. Dr. Sheetal, Dr. Stalin, Dr. Smriti, they have taken a different leap. And Neelam and Vartika, Dr. Neelam and Vartika, they are the anchors. And Manoj is always there. At the end, I always forgot so many things. Being a secretary, it's not easy for me to remember everything. My younger, elder brother, he's 1 year younger, 1 year elder, doesn't matter. But I always remember my elder brother, Dr. Manoj, to say something at the end before we end this issue or the class. Dr. Manoj.
Okay.
Sir, just a minute, Manoj sir. We can give we can do the most important job before the vote of thanks and by Dr. Manoj Kumar.
Okay.
Yeah. Giving the certificate, sir.
Oh, sorry. Please. Just give me 1 second. Is my screen visible?
Yes, sir.
So thank you everyone. Sorry, Dr. Manisha, and thank you. So nice of you to remind us this very important task. So Smriti, we are really thankful you undertook a very important case, and for the certificate is signed by our academic chair, Dr. Bhimeshwar sir, Dr. Divatar sir, president, myself, and Manoj Kumar, our this one program head, and Manisha Katikar madam was our program head. Okay.
Thank you, sir. Thank you so much for giving me the opportunity, sir.
Yeah, always there. We always there. And Sheetal Dalal madam.
Hello, thank you, sir.
Madam, you are there, na?
Yeah, I am here.
Yeah, ma'am.
Thank you very much, sir.
I had chaired the session with you in during YuvaCon.
Yeah.
So your potential, you are a good teacher, ma'am. And we really thank you for
Thank you,
being a part of this CRIS program today. Stalin.
Sir, thank you so much, sir.
You know one thing,
Yes,
Stalin has always is my younger brother, like, but his wife, that Sangeeta Dangar, she is also very active. So rather than giving to her, I gave it to this Stalin about this topic, because I know Stalin can give a better, the coverage to this topic. This is Stalin. You are having a little bit edge over Dr. Sangeeta.
Yeah. Hope I live up to your expectations, sir.
Thank you, Stalin.
Thanks for the opportunity.
Dr. Neelam Nalge, she is a very favorite student, teacher, friend, and senior of Maharashtra State. Madam,
Thank you so much.
you held this webinar in a very good manner. We're really thankful to you.
Bajwa sir, you are too kind. Thank you so much.
No, ma'am. No, I'm just as a normal. And Vartika, I have always known for exuberance and the dynamism from the Sholapur. Doctor,
Thank you.
when I was there in Sholapur during my this one, CME was there this summer. Vartika was one of the dynamic anchor and as well as a fashion showstopper. She was a showstopper. Thank you, Vartika, for that being there.
Thank you. Thank you, Katikar ma'am, for this opportunity.
Yeah. So this was thing. So we thank you everyone. And more importantly, I want to thank you, Dr. Ruchi madam and Dr. Paul Raffel, because they are the anchor of this wonderful series. They didn't
Their
care about
certificates, yes, sir. Their certificates are also there.
their certificates. I am the certificates. By thanking to them with their certificate, I am thanking Ruchi madam and Paul Raffel sir. I am their certificate. Whenever they want, I will be there. Whenever they want me to be there at their place. That is a certificate for them. Because
congratulations, our Honorable National Secretary, for taking the initiative in bringing out to deciding to bring out a guideline for this, because we are all following, in most of the things we are following American and
the
other
Western
guidelines. So that is something good, and big congratulations and thank you. You need not request all of us to come. You should, that is a statement which should come from you, and it should be there.
Yeah, we are ready for that. And with me, Dr. Manisha Katikar, she is a very hardworking GC member with me. and I bestow upon the responsibility of taking out the guidelines for the thyroid hormones and thyroid surgeries. So she will be involving everyone, especially with the CRISP series. Whosoever attended, she will be review the recordings also. And now I request Dr. Manoj, sir, our treasurer, honorary treasurer, to thanks.
Okay. Good evening, everybody. As we come to the end of the another webinar of the CRIS series, it is my duty to deliver the vote of thanks to all those who helped to make today event. First and foremost, I'd like to express my deep felt thanks to Dr. J.V. Divatia, President ICA National, and Bhimesar sir, Chairman Academic Committee ICA National, and all the governing council member of ICA National for their support for this event. I thank our Honorary Secretary ICA National Dr. Sukhvinder Jeet Singh Bajwa for having taken the lead and organizing this event. Thank you so much, our Honorary Secretary Dr. Bajwa, for a wonderful job. A hats off to you. I thanks all the esteemed governing council member, past office bearer of the ISA National, all the current state and city office bearer, and all the member of ISA. Thank you, our esteemed chairperson, Dr. Paul O. Rafael, and sir, and Dr. Ruchi Tandon, madam. Your guidance, leadership, and expertise have been instrumental in the shaping the direction of our discussion on anesthesia and endocrinology and thyroid disease. We are truly grateful to your dedication and commitment to advancing knowledge and best practice in the field of anesthesia. A special thanks to our distinguished speaker, Dr. Smriti Anand Madam, Dr. Sheetal Dalal Madam, and Dr. B. Stalin for sharing your expertise, insight, and valuable knowledge in the field of anesthesia and endocrinology and thyroid disease. Your presentation has been informative and inspiring, offering us new perspective and ideas to enhancing our practice. A special thanks to our academic moderator, Dr. Neelam Nalge Madam and Dr. Vartika Agrawal Madam for their meticulous planning and seamless execution, ensuring a smooth and successful events. Myself, Dr. Manoj Kumar, as a program head and co-program head, Dr. Manisha D. Katikar Madam, are grateful for the opportunity to come together as a community and advance our understanding of the anesthesia and endocrinology and thyroid disease. Let's carry forward the learning from the today's session to improve patient care and safety in our respective roles. Thank you once again. We look forward to your continuous participation in future events of CRIPS and CLIP series of the ISA National. Long live ISA. Thank you. Over to Bajwa and Dr. Manisha.
Hey, Manoj bhai, you made my work so simpler. You thanked everyone, especially our speakers today, Dr. Sheetal Madam, Dr. Stalin sir, and Dr. Smriti. So things are good. I think Dr. Manisha Katikar is being bestowed upon the responsibility of making the guideline. Dr. Manisha, these are the ISA guidelines, and we are very much serious about it. And these will go by our name, and they will be approved on the 8th of June on our GC meeting.
Yes.
The endocrinological guidelines, you will be the part of every guideline, and type to take all the people who are being present here, who have been active participant in the discussion today into those guidelines.
Sure.
They are not difficult to make because I have been a part of the endocrinology guidelines since 2012 in the ICU and the glycemic series and all these things. So they are very simple. The only thing is initiative and the hard work. And I think the people who have presented today, they are very hardworking people and anchors, moderators, everyone. You take everyone along with you. So we will come into the guidelines and we will publish it as a series of ISA guidelines.
Sure, sir.
We will not go by ASA guidelines, and I will sign those signatures. I will sign those documents myself, who nobody can question in the world about those guidelines because those will be evidence-based, those will be Indian evidence-based, and those will be normally Desi evidence-based, and they will be true guidelines. No nomenclature will be there fraud by the fraud guidelines. This is a fact. Actually, in the world, every guidelines, when they are made by the ASA, You never know the formalities, the methodologies, and evidence they have gathered. However, those guidelines, when they come on the screen, they are taken as a guidelines of the superiority. They are taken as a guidelines that these are the best guidelines in the world. But I think we have started a culture in ISA, the new guideline culture. By the next 1.5 years, we have at least have 10 new guidelines. I have already designed that. So endocrinological guidelines are the one. The series being will be managed by the Dr. Manisha Katikar.
Sure,
This is my dream. We should be coming out with those, and we should take everything into account.
Excellent initiative, Honorary Secretary.
Thank you, Dr. Manoj. You are my biggest pillar of strength, along with Dr. Manisha. So we will be coming out with that. No problem about that. Nobody can question. Indians cannot come out with a good thing. And Dr. Raffel is testimony to that. Even he knows that the Indians need to come up with that. Dr. Paul.
Yes, sure.
Isn't it?
Dr. Bajwa.
Yeah. So I think it's a time to say good night and goodbye. I think today we took too much time, but it was a wonderful session required. It was very much required. And we really are very much thankful to the speakers, to the moderators, and to the anchors like Dr. Manoj and Dr. Manisha, programmer. Everyone, we are thankful, not naming anyone. Please be in touch. Please be in coordination for the formulation of guidelines also.
And continue with our group.
This group will be there. So please be there. We will be coming up with a new guideline formulation.
Thank you very much.
And we always end the meeting by saying, long live ISA.
Long live ISA.
Long live
Thank you
ISA.
so much.